Nilima, if you're, let's start.
Very good morning.
Good morning.
So I welcome all actually for this organ donation webinar organized by Association of Medical Consultants, Mumbai. And we have a team of esteemed panelists here. First and foremost, I would like to invite our Honorary Secretary, Dr. Hemant Dogad sir, who will introduce and give an insight about this webinar. Dr. Hemant Dogad sir is a senior line member and a very important member of our entire society, and he's a practicing gynecologist and obstetrician. I welcome Dr. Hemant Dogad sir. Please say a few words. Thank you.
Thank you, Dr. Danish. Good morning, everybody, and welcome to this webinar of Association of Medical Consultants. समुद्र मंथन में अमृत की प्राप्ति हुई अमरत्व मिलवाने के लिए. You know, people, the gods and the demons, they wanted to be immortal. We have no other chance, but definitely the God has given that capacity and capability to live till eternity by donating our organs, saving life. And when that your organ which has been donated remains alive in some other body, you have achieved immortal. You have become immortal by with that. So the purpose of organ donation, bringing it the awareness, because the medical fraternity must know each and everything what is organ donation is all about. Then only we can spread it to general masses. With these few words, I welcome our president, Dr. Nilima Vaidya Bhamre, and invite her for her welcome address. Dr. Nilima is a gynecologist with a law degree. With this, she has been a secretary, vice president of Association of Medical Consultants, and also very active in other social organizations like Mumbai Dhadkan and being doctors. So welcome, Dr. Nilima, for your welcome address.
Thank you, Hemant, so much. And well, like you rightly said, you know, to be immortal, this is one of the ways. And as a doctor, we have the chance to create this awareness to a lot of public. Unfortunately, what happened was that when I took this post as the president of Association of Medical Consultants, organ donation was one of my prime focus. And what I realized is that the doctors themselves don't know much about what to do when something happens to a patient in their hospital and they have a death on hand. And if the patient has pledged his organs, then what are ways of going about actually doing that thing? So we needed to know the legalities behind it. We needed to know how prepared we need to be. As doctors ourselves, we set an example in front of our patients, you know, कि भाई मेरे डॉक्टर ने organ donation का pledge लिया है, तो it's an inspiration to others. So only pledging, was that enough? Only registering yourself as an organ donor, was that enough? I have a card, but no one knows about it. So will my organs still be donated? These were the queries which absolutely needed to be answered. Who was fit for the organ donation? What was the exact procedure? When can cadaver donation be done? When can live donation be done? How it will affect your life once you have donated? All these kind of questions were there. And I thought this needed to be addressed. And at the beginning of my year itself, if at all I can create this kind of awareness, I want to see at the end of the year how many of our own members, you know, decide to be organ donors. When I became president, I also promised to myself that I shall lead by example, and which we started doing with the first blood donation camp that we had. I was the first blood donor to start with it. At the same time, organ donation was something very close to my heart. So I had already registered many, many years ago. I have made my own card and I have told it to all my relatives and all my friends, and anybody whom I'm going with on a regular basis always knows, you know, if anything happens to me at that particular time, I want my organs to be donated. During the COVID time, one of my biggest wishes was not to die in COVID, because otherwise I thought my organs would not be utilized. So I was praying to God, me kuch bhi kar, lekin COVID mein mat maar. I'm willing to die anytime, anytime else. Now, that was about organ donation. There are a lot of exciting things that are happening in AMC now. The most important thing that is coming up now is the 3rd of July program. That is the Doctor's Day program. I want a lot of you to join us at Rangamandir, Bandra West. It's a fabulous venue. Our own past president, Dr. Suresh Rao, a person who has done so much for the society, is going to be felicitated on that day at the hands of none other than Dr. Himmatrao Bhaviskara, Padma awardee himself. This is part of the program, and the program otherwise organized for you is a musical by Sameer and Dipali, who are professional singers, and they do a fabulous job. On that day, we have a few interesting announcements to be done. So I want you to be there. I want our members to become inspiration for everybody. I want AMC to be established as a brand, just like Rotary and Lions Club is. You know, tomorrow, if anyone wants to say anything, we just talk about Lions and Rotary. I want AMC to be established in the people's heart. We need to change our image in front of the people. But how can we do that? Not just by, publicizing this and that. We actually need to do good. We need to show the society that, yes, doctors are for the patients. Patient safety should be our prime focus. Automatically, I feel things will change for us. Communication, empathy are very, very, very important. From my point of view, I'm trying my best to get my members involved in all the programs, all the medical legal programs that we have. We've started also approaching all the periphery. We've had 2 programs, one in Alasupara. We had 1 program in Thane. So we're trying to reach the absolute outskirts of Mumbai and the periphery wherever we can possibly reach. So from our side and from my team, I have a fabulous team this year who is so excited to do everything, and everyone is leading by example. We are doing programs where different people are leading the team. Every program, we have a different convener who takes part in the entire process. So we're trying to create leaders over here. We're trying to guide them at every stage. And now today's program is organ donation. I shall stop over here. I think I've spoken too much, as always. And to partner with us for all these fabulous initiatives that we are trying to do. Blood donation camps is something, was a vision of Dr. Hemant Dugad when I told him that blood donation is something I want to do. He said, Nilima, it's 51 years, let us do 51 camps. So we want members also to come forward and say that, yes, we can organize a camp and we will try and help you out wherever we can possibly do it. Now, to do all these programs, we definitely require financial support. And we have educational partners who have understood my quest for doing good for the society, and they have joined in with that pure heart. So can we have 1 or 2 videos, if at all? I do have 2 minutes, I think, still left. If you could play the videos for me, please.
Yes, I'll just share the screen and just see whether the videos can be played. 1 second. Huh? Okay. Let me just...
Shruti, 1 minute. First, we are playing the Innovate. We are playing the video from the sponsors. Pranab, can you...
Okay, sure.
See, these are people because of which all these things are possible for us to do.
Thank you so much, Dr. Nilima, our dynamic president, who has actually, as she said, this has been one of her passions, and I'm very happy that we are kickstarting the year with this very important program on organ donation. Dhyanesh, over to you, please.
Yeah. Thank you very much. Thank you very much again, President Madam, for giving that inspirational speech. And it was actually her vision, and it is all the entire teamwork of dedicated AMC members, which actually is making the difference this year very particularly. So, and again, we would like to thank Finovate for supporting our webinar and giving valuable inputs. Next, I would like to invite Dr. Shruti's PowerPoint, her presentation, and she would like to show one video on organ donation. Please, can you please share the screen?
Yeah, I'm trying to share the screen. Let us hope that it plays.
So till Shruti shares the screen, I will take the opportunity. Shruti, this is not your main talk, but we are going to have Shruti's talk a little later. We are having a small video on organ donation now, after which our convener, Dr. Manoj Patel, will be giving us a little bit of insight, after which Dr. Shruti will be giving her talk.
Yes.
So just for me to give a background to people, that I'm associated with a foundation known as Narmada Kidney Foundation and an active worker. And every year we invite movies on promotion of organ donation. So this is one of the award-winning movies which did a lot of good job in promoting organ donation. So let's hope this plays.
Shruti, make it full screen, please.
Yeah, I did.
Thank you. Thank you. Volume doesn't seem to be on.
Volume is on actually.
No, we are not able to hear the volume of the
video.
Okay,
let me increase it.
Yes.
Yep.
No, unfortunately, I think
no.
Shruti, maybe we'll take your video a little later. Dhyanesh, let's try to figure it out.
Yes,
Dhyanesh, if we can proceed with the rest of the schedule.
Yes. I think we'll put that video a little later on.
Yeah.
Now I would like to welcome our program committee chairman, respected Dr. Reena Wade madam, who can actually share and guide us for this wonderful webinar on organ donation. Madam is a professor at Cooper Hospital, and she is a senior gynecologist and member of MOGF, and she has a lot of accolades to her credit. I would like to invite Dr. Reena Wade to guide us for our remaining webinar of this organ donation. Madam, please.
Thank you. It's my pleasure and privilege to be associated with this program today. And I feel, जैसे कहते हैं राजा या रंक सभी का अंत एक सा होए. And that is something in our own philosophy and how we look at life. And COVID has changed our perspective in so many ways that we want to be immortal, leave our mark. So organ donation is one of the ways that is going to help us. But often it happens that people struggle to really implement it. And I'm really glad we have a wonderful team of speakers, all of whom are actually doing groundwork in the field. And I really appreciate all four of them having taken the time off to be with us today. And I would request each and every one of you who are participating in this webinar to type your questions as they come into the chat box. At the end of the program, our MOCs will be collecting all the questions, and all four speakers have agreed to be with us at the end so that we have half an hour interactive session before we wind up. So please, friends, feel free to type in your questions into the chat box, and we will be taking the questions. And we look forward to inputs from all of you, because interaction is very, very important in the way forward. During the course of the program, we have 2 of these educational videos about organ donation, which have been prepared also one from the ZTCC, which not too many people know about. So we will be sensitizing all of you to that. With these few words, I would like to invite our program convener for today, Dr. Manoj Patel. Can I have his CV, please? So Dr. Manoj Patel is actually has been working in this field silently since many years. He's a zonal director of AMC and a consulting physician practicing in Santa Cruz and Bandra since 40 years. And we are very happy that he will be giving us a few practical tips on what we as doctors and physicians can do in this very important area. So we welcome you, Dr. Patel, and over to you.
Thank you. Thank you, Reena. I welcome all the participants. Beautiful seminar. The organ donation, as the in general, our President Madam and Secretary has already told. In general, organ donation, what we are trying to do is awareness of organ donations amongst general populations and especially amongst doctors. Now, why did this come? Because general population, unless they know about organ donation, there are a lot of reservations. Now, reservations as far as the legal, as far as the spiritual or religious things are there. So gradually we have to remove all those things from their mind and spread awareness. Now media is playing a big role. Many NGOs are doing organ donation drives. Now why AMC? Now for any time after demise, the first point of contact is a doctor. Now, if a doctor is well aware of organ donations and where and which organs and in which person can be donated, in that case, he will motivate or he will counsel the relatives of the patient. And that is the time I think organ donations can be increased. Because at that time, if few hours are just wasted, then all those organs are wasted. Then the first point contact is not counseling the relatives. Now in AMC, we have a big pool of nursing homes, hospitals. That is where sometimes, God forbid no, but sometimes the brain death patient, if it is there, that's a first program where the doctor concerned can counsel the relatives and provoke them to give organ donation. Now, simple things like eye donations or skin donations can be done by anyone from home also. But the other major organ donations, I think our pool of hospital can do much better. So, spread organ donation awareness about skin and eyes, which can be easily done. Plus, they can be told that all the other organs can be donated in case of brain death and in the hospitals, because they have to be pulled on, the circulation and other things have to be maintained before organ donation. So our doctors, once they are sensitized, our doctors, once they are aware, need to spread it in general public so that they are receptible to the idea when the doctor counsels them. But I think finally it comes to a doctor as a first point contact after the demise. And at that time, the emotions are running high. So that time to counsel is a real tricky thing. But I think once we achieve that, many more organs can be donated. Some of the countries have only negative consent. That means if you don't want to donate, you said no. Otherwise, all are taken as organ donors. Still, legally in our country, that is not the true thing. Right now, even if we prepare a card for organ donation and all, after demise, our relatives and the families have to be aware and this have to be counseled for this to be prepared for organ donation. I think that should be good enough because our doctors are going to be sensitized. Once we sensitize our doctors, the contact and the awareness and the ratio of conversion of organ donation to counseling is going to increase. Thank you. Thank you.
Thank you so much, Manoj sir, for a wonderful insight on the organ donation. Now I think I will respect the admin to play a video
Yeah. Dr. Patel has highlighted very important 2 or 3 points, sir. One thing is the fact that we may have an intention, and it has been said that the smallest good deed is better than the biggest good intention. We may have very good intentions कि हमें ये donate करना है, वो donate करना है, but to get it actually implemented into practice, the family has to be kept in the loop from the beginning. And there are issues about how to declare some brain death. Is there a time to harvest the organs? All these issues come up. And definitely our speakers, that's why we have asked them to talk about living donation also and cadaver donation both, so that both these issues can be highlighted and how we can take it further. Another very important point that Dr. Patel talked about is negative consent. For example, Spain is a country where only if you have said, I don't want to be an organ donor, your organs will not be donated. Otherwise, it is considered as a given that everybody is going to be an organ donor. So I think, of course, we have a long way to go before we reach that area. And now, before we, Dr. Shruti is going to be our first speaker, but before that, I'm going to request her to play one sensitization video which has been made just to give an idea, and we will try technologically how, you can share the screen directly.
Yeah, that's what I did. I'm sharing the screen
Share
directly.
the screen, and I hope the audio works this time. Technology is challenging, yes.
Working?
Yeah, let's have it play. Pranav, you can help her in this.
You will have to share the screen again.
Okay.
You press share screen and
I did.
You can use open the application with your VLCC media player or whatever you have stored on your computer.
This is on YouTube actually.
Oh, it's on YouTube.
So share screen kiya hai maine. Now I'm stopped.
Then Shruti, I would suggest let Dhyanesh introduce you and go ahead with your talk, and we will share the YouTube link with our technology team. Pranav is, I think we should let each one do what they are specialized at.
Yes, correct.
So
I will do that.
Let him figure out how to share it from YouTube. We'll do it after your talk or in between talks.
Sure.
So I think, Dhyanesh, we can officially introduce Shruti now.
Yes. Now I would like to welcome Dr. Shruti Tapiawala, who is a senior consultant and transplant physician. She is attached to Global Hospitals and HN Reliance Foundation Hospital and Research Center, Mumbai. She is also a laboratory director of ATDI Lab Private Limited, Mumbai, secretary of ISN West Zone Chapter, joint secretary, Women in Nephrology, India, managing committee member of Mumbai Nephrology Group, trained in multi-organ transplant and HLA medicine, established state-of-the-art transplant immunology laboratory, initiated sorter sensitized recipient registry. Madam, please give your valuable inputs on this webinar.
Thank you so much for giving this opportunity to share my expertise, and it is my pleasure to be on this platform to try and promote organ donation, share my knowledge, and I'm hoping that we'll have more and more people to be helped. So let me start with my subject today, that living and cadaver kidney donation and transplantation. So what is end-stage kidney disease? Let me start with that, because before that, we know that there are acute kidney injuries, chronic kidney injuries, which slowly can progress to end-stage kidney disease. This is a stage where practically the entire kidney function is lost and the kidneys can be considered to be totally dead. And this is a stage where, we tell patients that, see, your kidneys have shrunken in size, there's no function. And now if you do not act, then your body is going to die of deficiency of renal function, which can be acidosis, severe lethal hyperkalemia, fluid overload, and uremia. The only two options left in this situation are lifelong dialysis or a kidney transplantation. So it is simple that if I have toxins in the body and I have excessive water in the body, I need to remove it. When I remove it artificially, I do it via dialysis, which can be PD or hemodialysis, which is not the subject for today. And the best option remains transplant. Now, why transplant remains the best option? Because I do hear patients telling me that, doctor, I am comfortable on dialysis. Why are you pushing me towards transplantation? So let us look at that. So, in 1999, there was this landmark paper in NEJM where, you know, they tried to answer this question, because this was the very beginning of transplant. 1952, the first ever successful transplant was done in the world by Dr. Joseph Murray at Harvard Institute. But after that, it was a big steep hill, because we had only steroids as immunosuppression. 1980 onwards, we got cyclosporin and we got more medications like azathioprine, which were being used. And now the transplants were being successfully done. But then the question remained, whether is it worth putting the patients through the immunosuppression, through the surgery, or whether dialysis was better. So this is the landmark paper where around 46,000 patients on the waiting list, that they were fit to go for transplant and they were waiting on dialysis. And we wanted to see what happened to people who did not get a transplant and what happened to people who got a transplant. So this is the survival graph where we saw that at 106 days, the survival equalized. So if you get a transplant, your risk of dying reduces. And if you do not get a transplant, you start dying faster. So this was a landmark paper which changed the perception of people all over the world that no matter what, dialysis cannot equate the natural kidney function, because the middle molecules, the large molecules, do not get removed via a dialysis machine or any kind of high-ended dialysis. A natural kidney or a original kidney is only going to be able to do that. And if we have large molecules, middle molecules, and renal dysfunction continue, then it is going to end up having people having more cardiovascular mortality, more bone mineral disease related vascular calcification, and deaths. So it was noted that the mortality of patients who remain on dialysis was much higher than people who went for transplantation. Now the next question comes is, what is the success rate? That, okay, this is good, but what is the success rate? So over years, we have achieved a lot of perfection. So I can say with personal experience that we have 25 and 30-year post-transplant patients following up with us with a creatinine of 0.8 and 1 with minimal immunosuppression. But this is the actual real graph survival, that if you have 100 patients going for transplant today, then at 5 years, I will have at least 88% of people surviving and at least 80% of kidneys surviving. So which is a very good thing, because if you look at dialysis, the dialysis mortality is so great that within 5 years, the mortality comes to 50%. So it is a very great difference which we see in the survival rates of patients when I compare it to transplant. Now, what is the rate worldwide? So worldwide in today's date, 4 lakhs of transplants to 5 lakhs are being done. Only kidney transplants I'm talking about, not the other transplants. The 1 year actual real survival is 85 to 95%. 5 year is 85 to 95%. 10 year is 50 to 65%. But like I said, there are people who go on for 20, 25 years, and the actual T-half or the half-life of a transplanted kidney is anywhere between 10 to 15 years minimum. So this is quite a good result, which is encouraging. Now, when to do a transplant is the next question, because people have this conception that, okay, you have end-stage kidney disease, go on dialysis, remain on dialysis for some time, then we will do a transplant. No, dialysis is not required. The moment you are approaching end-stage kidney disease and your glomerular filtration rate or your creatinine clearance drops to less than 15 or less than 20, I would say, start preparing. I start preparing the patients right from that time that, look, you are approaching this stage. If we prepare right now, your body will not have to go through dialysis. And this is a proof for that a preemptive transplant, that means a transplant done even prior to starting dialysis, is always better. If you see the upper graph, you can see that the survival is much more superior by 2 to 3 years than if you are getting dialyzed. So the more you get dialyzed, the survival rate keeps going down. So I keep telling patients dialysis is no good because your body is full of toxins 90% of the time, and only 10 to 15% of the time when you are on dialysis is your body clean, and which is not what your body wants, because your heart, your brain, Your vasculature is getting damaged continuously when you are on dialysis, because dialysis is not able to clear middle molecules and large molecules, and these are the toxins which accumulate over time and cause end organ damages. So numerous studies have provided convincing evidence that renal replacement therapy with preemptive renal transplant is advantageous for a patient and allograft survival. Avoidance of dialysis is associated with comorbidities, further supplements and benefits of preemptive transplant. And from the perspectives of recipient, donor and the society, because it adds to the economic burden when someone goes on dialysis in form of vascular access, going to the dialysis unit, all the consumables. So this is a much effective therapy. Now, what is the cost? Because that is the next question. So I am taking this talk in a very practical manner as to what questions arise in someone's mind when someone is thinking of a transplant. So in today's day and date, if someone is to go on dialysis, the cost of dialysis per month is at least 40,000 per month. If you count the consumables, you count the dialysis sessions, you count the dialysis consumables, you are traveling to the dialysis session, and not to forget that every year you have at least 2 to 3 hospitalizations per year when you are on dialysis, because you have a vascular access issue, you have infective issue, you have cardiovascular issue, you may have a gangrenous issue. And we see this practically in every patient, that every year minimum 2 hospitalizations happen for any patient who's on dialysis. This worsens the economic load. Plus, this patient is not able to earn because no one employs a person who cannot come 3 days a week. Transplantation, the initial expense at any standard hospital is around 6 to 7 lakhs. Added is the medication cost. So I would say in today's day and date at an average hospital, it goes to around 10. But that is worthwhile, because the moment you are transplanted, after that your cost slashes down. Because in the first few months, till 6 months, you can say the cost is only 15,000 a month. And then after 6 months, because we reduce the immunosuppression, it becomes to around 2,000 to 5,000, and the person is back on their job with their family life. So this is much more gratifying, much more economically viable for the patient, and the patient achieves a near normalcy of life. This is very important. You cannot have a family remain sick because one of the family members is unwell and continuously has to keep visiting hospitals. Now, who is eligible for transplant comes the next questions. So all the patients with end-stage kidney disease should be assessed for suitability of kidney transplantation. Patients who have cancer or actively having some infections cannot go for transplantation. These are the only 2 reservations we have when we contemplate someone to go for transplant. We look for cancers who are actively going through chemotherapy or are recuperating from cancer and not past the 4 to 5 years beyond the cancer, where we know that relapse is not going to happen. We always take opinions from the oncologist that what do you feel about this cancer type? What is the chances of relapse over how many years? We'll wait for that much time and then go for transplant. Infections, try to treat the infections, get rid of the infections, and then go for transplant. Like active ulcers, gangrenes, all this, we will never want to attempt something when there is an active medical issue on. Now, what are the special assessments? Because these are in our mind, and most of the times the patients are like, no doctor, my age is 60, how am I going to go? But 60 is not old age. Now the age remains more than 75 that you become old, because now the life expectancy and the medical science has improved so much that people are healthier even at the age of 70. Severe heart disease, lung disease, liver disease. I will show you examples in the due course that how we deal with these patients. HIV positivity. Now, this was a definite no-no 10 years ago. But in our group itself, in our center itself, we have 4 HIV positive patients who have been transplanted successfully, and they're doing well. Now, obviously, if you have an AIDS complex, if you have things where you have an active infection, you will not intervene. But if you have a stable HIV patient whose viral load is less, whose CD4 count is normal, these are the patients where we will not deny them transplantation. We will give them an opportunity for a normal life. Psychiatric illnesses. If the patient is able to take care of himself and there are enough caretakers and has enough support system, we will not again deny transplantation and keep the patient on dialysis. Now, what about the donors? Donors baseline have to be healthy, no active metastatic malignancies or any infections. Renal function on DTPA scan. This is a nuclear scan. And we have to look age-related corrected scans, and more than 65 milliliters per minute with equal function both the sides is going to be acceptable. So we very, very meticulously scrutinize the donors so that we are very careful in picking them up so that they are healthy throughout their life and the person who is receiving the organ is also not harmed. Now, exception is diabetes, because it is a general exception that old people and diabetics will not be able to give. But no, if you are a recently diagnosed diabetic and your sugar is well controlled, you have a disciplined lifestyle and there is no target organ damage like proteinuria or retinopathy, then we have still accepted, and there are responsible families where they keep a watch on themselves, and we have not seen people having renal dysfunction over a long time. Now, let me start with this case. A 69-year-old male, diabetic, hypertensive, maintenance dialysis for a year when the patient came to me. Family was counseled for transplant that why are you on dialysis? But they were not convinced because they were scared. See, it's always that a patient gets comfortable with whatever he has been put on in emergency. Then they don't want to go ahead unless they see the positivity or the negativity of the therapy they are on. He had recurrent presentations in the emergency department with fluid overload. And I have counseled them. I said, see, this will keep happening. So you have to be ready. If you want to be on dialysis, your heart, your brain is going to keep getting damaged. You will have recurrent admissions and you will have to be prepared for it. Now the family was convinced. So now they asked me, where do we get a kidney from? So I explained to them, it can be a living donor or it can be a deceased donor. Now, what can be a living donor? So in our country, what is a related living donor? It is either parents, grandparents, children more than 18 years of age, brother or sister, spouse, wife or husband. If these are not possible, then you go to a second ring, which is the cousin brothers, cousin sisters, or you can go to your in-laws. These are also related. These are related to you, but they're not near relative as per the legal definition. And you will have to approach the government DMER where regular meetings are held and these cases are scrutinized. And if they find that these are logically, legally, properly related, they do give permissions, and this is not a difficult process. Government has simplified it very nicely so that patients are not inconvenienced and patients do not suffer because of bureaucracy. What about match? We see blood group compatibility. We see the HLA typing because we want to see the tissue match. We also see whether there is any tissue reactivity, whether this organ is going to be rejected or no. And then we plan immunosuppression. Now, what was done for our patient? So now the patient agreed because now the family understood that they are in a grave situation where things can go wrong. So now the wife, who is 65-year-old, bronchial asthma, no other comorbidities, came ahead. The blood group was matched. The DTPA GFR was 75 milliliters per minute total, 40 ml on the right side, 35 on the left. We look at individual kidney function so that we know that both the kidneys are functioning optimally. And then the urologist has the choice to pick up a kidney which is simple enough with one single renal artery and vein to be transplanted. All medical fitnesses, including cardiology, everything was thoroughly done, and the transplant was done on April 20th, 2016. I have deliberately chosen old cases because I want you all to see the success. Today, at the age of 75, I just checked my software records. He's 75 now. He's fit with a creatinine of 1 milligram per DL. His wife is well with no new comorbidities. Except for bronchial asthma, she is on nothing, only inhalers. So her creatinine is 0.8. So this is to show you that getting worried, getting scared because of age is just a number. You have to see the phenotype and the genotype. What is the patient? So never close the eyes towards a therapy which is going to give you a new life. Now, the next point. What if you do not have a blood group matched donor? What will you do? Because many a times in 10 to 15% of the situation, there are willing donors in the family, but the blood group is mismatched. Then what do? we have two options. One is we go for a paired kidney exchange, means you go for a swap. That means you exchange kidneys of two families. So one donor gives to the second family and the second donor gives to the first family. I'll show you an example. And the second option is you go for a blood group incompatible transplantation. Now this seems to be very challenging to a non-sensitized population who doesn't do transplant, but for us it is a routine. I will show you a case for that. So what is a paired kidney exchange? Say the family 1 recipient or the patient has blood group B and that patient's donor has blood group A. So obviously A will not give to B. Family 2, if we find out such a family has a blood group A and the donor has blood group B. Simple. The donor of the second family will give to the first family's patient and the donor of the first family will give to the second patient. The blood groups get matched and things are simple enough that the transplant can take place normally. Now, this is a live case from 2010. Again, I'm saying I've picked up very old cases so that you can see the success rate. So here, this young male was on dialysis. He was a hypertensive who landed up on dialysis, and wife was a suitable donor, fit donor, willing donor, patient B negative and wife A positive. Given options for transplant across ABO barriers or paired exchange, they planned to wait because they were arranging for their finances. Meanwhile, a patient from Gujarat came across similar age group. Again, here the patient was A and the wife was B. So after waiting for around a month or so, the second patient was on dialysis for 3 years, and my patient who was with me in Mumbai was on dialysis for a year. Now at this time, we came across a similar cross pair and I made the families meet. We did all the paperwork and it took time because Gujarat government and Maharashtra government, we required 2 NOCs. But we went ahead on 2013 Jan 10th and today it is 10 years and the patient is doing well. So, this is very gratifying that, you have to simply tweak your brain and you have to work. Now, what if there is no swap pair? What if we kept waiting and waiting and waiting? Because dialysis is going to add to morbidities and mortalities. So we cannot have the patient keep waiting on dialysis if you do not have a suitable pair. The next step is you have to explain to them that don't wait, just go ahead with a blood group incompatible transplantation. Now, how do we do that? So we all know the blood group system. Blood group A will always have anti-B because that is why we do not give a cross blood transfusion. Blood group B will have an antibody to A. Blood group AB will have no antibody, so they are universal recipients. Blood group O will have anti-A and anti-B both, so they cannot receive from anyone, but they can give to everyone. So this is our blood group system. Now, suppose I give an organ to blood group A, which is B. Anti-B will come and attack, and that is what will cause the rejection. So that is why we always match the blood. Now, suppose I want to do a blood group incompatible transplant. What will I do? Simple. I will simply have to remove these antibodies from the circulation at the time of transplant and the transplant is done properly. How do we do that? We have something known as a desensitization process. So we remove the preformed antibodies. So all our bodies have antibodies against the reverse blood group. So those preformed antibodies will be removed by plasma exchange, which is a similar process to dialysis, which the patient is already on. Then I will give medicines which are used for transplant, like steroids, mycophenolate mofetil, tacrolimus, which is to be started 2 days prior. I will start 14 days prior. I will give rituximab, which is a B cell suppressant. And this all helps in reduction of production of antibodies. So with these 2 processes, I can minimize the antibodies, bring them down to a level where I can transplant. Now, this is a case, again, a past case. Young lady with CKD since 3 to 4 years, now progressing. She agreed for a preemptive transplant. Mother came forward as a donor, medically fit. Patient's blood group was O, but the mother was A. And the amount of antibodies, that is the titer we call it, was 1 in 128. And what do I want at transplant? 1 in 8 or 1 in 16. This is how much is tolerable and the organs don't get rejected. So we initiated on plasma exchange with medications 2 weeks prior, underwent successful renal transplant in April 2017, discharged on day 10. Creatinine was 0.7 at discharge, and last week's follow-up creat is 1.2. So she's doing well. Her mother is doing well. She had her husband who was a suitable donor with a blood group match, but she wanted her mother to give. So we went ahead with the blood group incompatible transplantation, and it has worked well. And this is one of the hundreds of ABO incompatible transplantations we do nowadays. Even the liver transplant team does ABO incompatible. I'm sure Dr. Amit will allude to that, but this is from the kidney point of view. Now, the last case for today, 52-year-old male. This is a different scenario now. 52-year-old male, diabetic, NASH-related cirrhotic liver disease, also developed CKD because of diabetes along with liver disease. So he required a transplantation of both kidney and liver. So this was a difficult situation. Liver also living donors can give, kidney also living donors can give, but here the family has to search for 2 donors. So we counseled the patient that, you know, we will have to find 2 donors from the family, or we list the patient for cadaver transplantation. Now a patient on dialysis can remain on dialysis till they are allotted a kidney, but liver disease can be dangerous, and liver does not have any kind of bridge dialysis or anything to support the patients, and they might just succumb to their disease. We had to explain this to the patient. What did they do? The family, the wife came forward as a kidney donor, son came forward as a liver donor. The patient had severe liver disease and was in the hospital for 2 months because these patients are very sick. Once stabilized, a simultaneous liver kidney transplant was performed, recovered gradually post-op over a month, and now he's following up as a normal patient in OPD. It is 4 months after this transplant. So see, there are success stories if done carefully, scientifically. Now a little bit 2-3 slides on cadaver donation. Who can be a cadaver or a deceased donor? A brain dead individual, meaning the brain which has the reflex center in the brain stem has stopped functioning due to ischemia, road traffic accident, or an IC bleed, and the brain reflexes have just been terminated. So there is no respiration, there is no circulation, and everything is being supported by artificial life support. And what is the regulation around this? So the government of India adopted the Transplantation of Human Organs Act in 1994. It regulated the removal and transplantation of human organs, permitted removal of organs from brain dead individual for the purposes of transplantation. So this is the legal law which India follows since 1994 to facilitate organ donation. What are the implications of brain death? If you have a brain dead individual, the person is dead any which ways, and we are supporting the patient on life support system and without any outcome. So 2 things. One is that a deserving patient does not get a ventilated bed. Second, a deserving candidate who has end-stage organ disease does not get organs. So this is a win-win situations in every system which you can look at, and that is the concept of organ donation after death. Now, what happens in Mumbai? So in India, we have NOTO, ROTO, SOTO. So NOTO is national, then regional, and then state. And in the state of Maharashtra, we have ZTCC. ZTCC is Zonal Transplant Coordination Committee, which is housed at Sion Hospital in Mumbai. It maintains a list of all the people who are registered for deceased donor organ transplantation. Say a patient does not have a family donor, can be listed there. The treating doctor can fill up the form and forward it to ZTCC. The hospital forwards it to ZTCC, and ZTCC maintains a blood group and age-wise list. They have a working staff which is day in and out trying to help patients get kidney, and I have a video on the back end of ZTCC working if we can play it. Points given are based on months of dialysis, number of fistula or vascular access failures, number of transplant failures, and these people keep getting merit points. Whoever is the highest on the list will be allotted the kidney whenever it is available. It is blood group matched and it is age matched. So it is not that a 70-year-old kidney will be given to a 20-year-old waiting recipient. It is always age group matched. And in the middle of the night, we have to do all this when we get calls. The ZTCC works out that so-and-so hospital has a donor and your so-and-so patients are on the list. Are they willing to come? Are they financially ready? Please call them. So this is how it goes ahead. But The list has around 3,500 to 4,000 people, and the waiting period for any person listing today is minimum 4 to 5 years, because the list is pretty long and our organ donation rate is not as good as it should be. Now, let me just touch upon 2 slides for the surgery and then we end. So how is the surgery done? Just for the common knowledge sake, that if you see from a recipient point of view, we do not remove the native kidneys and we place a third kidney in the iliac fossa. And from the recipient, we take one of the kidneys laparoscopically. So now no longer open surgeries are done. This is for the living donor. If it is a deceased donor, then it is a meticulous surgery where all the organs are retrieved and harvested and sent across to hospitals. But in a living donor, it is a table-to-table transfer and there are 2 OTs running simultaneously. Laparoscopic donor nephrectomy. So the donor is discharged within 3 days of the surgery. And the transplant is simple. It is vein to vein, artery to artery, ureter to bladder, and it is done. So we simply in our language call it plumbing. Surgeons may find it very crude, but that is the fact. So surgeries can be open, they can be laparoscopic. Recipient wise also surgeries can be open, they can be robotic. So now with modern science advance, we have all the options available to see that a fat patient can get a robotic surgery so that the healing is not difficult. So what about donors? We admit them 1 day prior and they're discharged on the 4th or the 5th day. They do not usually have any problems throughout their life. And this is a worldwide literature that only 5 to 10% might have some kind of hypertension after 10 years. Essentially, they lead a normal life, living donors. Recipient, perioperatively, we individually immunosuppress them, tailor-made immunosuppression, because everyone will have a different risk of infection and immunological events. Recipient is usually discharged on day 7 without any tubes in there, and they follow up regularly on OPD basis. Essentially, a very normal life is what they lead. Last word on xenotransplant, because this is where the next set of organs are going to come. Living donors, dead donors, animal donors. So this is a new advance which the world is working on since last 20 years. And recently a pig to human transplant happened and the kidney lasted in the human being for 2 months, but then it gave up. So what is the problem with this? This is our first xenotransplantation which happened in our country, but this was a concept which was put forth by our ancestors. And that's what tells me that our ancestors had a rich knowledge in medicine and they could conceptualize this, and now modern science is working on this. So there is an extreme shortage of organs and the genetics of the pigs and is very similar to human beings. The working of pigs is very similar to human beings. Hence, pigs have been chosen that they can be the potential organ source. But there are multiple viruses which are endemic to this species, like the retrovirus from the pigs. There is a genetic change from the human being to the pigs, which causes a lot of rejections. So that has been now engineered and the gene has been removed. And these are genetically engineered pigs, which are being harvested to use as potential organ donors. Now, there are a lot of ethical issues around it, but this is a progress which I want to put forth to you. And to summarize, transplant remains the healthiest option for patients suffering from end-stage kidney disease. Preemptive transplant, that is even before dialysis can be started, is the best. A blood group incompatible transplant is good option if the donor is blood group incompatible. At any point, remaining of dialysis is not an option. Cadaveric or deceased donor transplant remains a better option for patients who do not have living donors in comparison to remaining on dialysis. Thank you.
Thank you very much, Shruti Madam, for that wonderful talk on kidney donation and transplantation. I must appreciate your wonderful insight on the entire topic. And I'm sure all the learned listeners must have learned much, much more on organ donation of kidney transplant today. Thank you very much, Madam. Admin, do we have Madam's video with audio now? Is it possible?
I have no idea what we are going to do for that. We'll, I think, continue the talks. Let me
Okay.
and Mr. Pramod work at it.
Okay, okay, fine. Thank you, ma'am. Thank you. Okay, then we'll move on to the second speaker now. I would like to invite our second speaker, Dr. Amit Mandot, who is a consultant gastroenterologist and liver transplant physician. Is a national gold medalist in DNB in gastroenterology. Is a clinical lead, Department of Hepatology and Liver Transplant, Medicine Global Hospital, Mumbai. Honorary gastroenterologist to the Governor of Maharashtra. DNB teacher and academic in charge, Department of Gastroenterology, Bombay Hospital. Director, the Gut Clinic, Daycare Gastroenterology and Liver Clinic. And he has 20 publications in various index journals to his credit. I invite and welcome Dr. Amit Mandot to give his talk on the liver transplant and liver donations. Dr. Amit is here. Hello, Dr. Reena. Can you have Dr. Amit now, the next speaker, after Dr. Shruti? Okay, we have some time till I think Dr. Amit joins. Anyone has any question for Shruti madam? Madam, would you like to take some question if there?
Yeah, sure. Amit is just joining. I spoke to Amit.
Okay.
Hi.
Okay, Dr. Amit, please welcome. Most welcome here.
Volume.
We can hear you, Amit.
Yeah. Now I can hear. Sorry, my. So can I start the presentation?
Yeah, please start.
So I'll have to. I'm allowed to share the screen, Shruti. Hi, Jnanish.
Hello. Hi. How are you? Admin, can you please make Dr. Amit a co-host so he can share his PPT?
No, he's allowed to share the screen.
Yes, thank you.
Yeah. So good morning, everyone. We will talk about the liver transplantation. So everything about organ donation and liver transplantation. So we've had this wonderful morning session, which is very, very important in the bigger scheme of things about organ donation. I'll be talking more about the medical aspects of liver transplantation and how poorly we are doing in terms of cadaveric organ transplantation in the field, especially of solid organ transplantation. So we all know that the initial liver transplant techniques were done using dogs. It was first in 1960, and then we all know the father of liver transplantation, Dr. Thomas Starzl in Pittsburgh. So he did the first human attempt, and the first successful liver transplant by was Dr. Starzl in 1967. But initially, the surgeries would go on well, but there was a huge problem with immunosuppression, and most of the patients would die in the post-op period. So once the CNIs, once the immunosuppression became a reality in early 1980s, liver transplant became a clinical reality. And definitely in 1983, it became one of the definitive therapies. And with the development of University of Wisconsin solution, UW solution, which is the solution for graft preservation, transplantation, the cadaveric transplantation really took on, and with great success and great outcomes. And In 1992, the first liver xenotransplantations were done by Dr. Zakis. So as far as India is concerned, liver disease is the 5th commonest cause of death, and more than 20,000 liver deaths in India can be avoided by liver transplantation. And importantly, the liver disease affects the younger age group or the more productive age group. Of course, it's spread across decades, but majority of these lives saved would be less than 55 years of age. But unfortunately, more than 80% transplants in our country are live related, and it needs a healthy donor to undergo a hepatectomy on himself or herself. That is very successful, but finally it needs a surgery on a healthy person, which if organ donation is much more significant, then it can further reduce. According to the latest WHO data published in May 2014, the liver disease deaths in India have reached almost 2 lakhs or 2.44% of total deaths. And cirrhosis is the 10th leading cause of death for adults in India. So what are the indications for liver transplant? One is an acute liver failure. We all know the patient was absolutely all right till a few days back, and suddenly he develops a liver disease. He develops jaundice. He goes into encephalopathy, liver failure, high INR, immediate risk of mortality, almost 80 to 90% in severe forms. Or the more chronic liver disease, the cirrhosis. Once the cirrhotics develop complications like ascites, chronic GI blood loss, encephalopathy, liver cancer, refractory variceal hemorrhage, or synthetic dysfunction. So when a cirrhotic becomes decompensated, when he or she develops these clinical complications, that is a sign that the liver reserve has gone significantly low, and he is at the risk of higher death, higher morbidity, higher recurrent hospitalization because of these complications. And that becomes an indication for liver transplant. Then, of course, there are these liver-based rare metabolic conditions. Some of them are rare. Wilson disease, not so rare, especially in the pediatric age group. So we are seeing a lot of pediatric patients, a lot of pediatric transplants happening because of this metabolic liver disease. And then there is the systemic complication of chronic liver disease like hepatopulmonary syndrome and portopulmonary hypertension. Acute liver failure and transplant, more commonly studied in the West because of paracetamol poisoning. There are certain criteria. Let's not worry about those criteria. But basically, if the INR is very high, more than 6.5, or if the lactates are high, patient is sick, is encephalopathic grade 3 or 4, that means the patient has gone into liver failure. And these patients, if not transplanted, have a 80 to 90% risk of mortality in the next few days. So once these criteria are met, a transplant is indicated. If it is a non-paracetamol-induced ALF, like in our country, say a viral hepatitis or anti-tuberculous drug-related liver injury, and then if the INR is more than 6.5, encephalopathy is present, jaundice has been more than 7 days before the death. These are like poor prognostic criteria. So if the patient has any of these, needs an early transplant, and the Zonal Transplant Coordination Committee, the ZTCC, which is responsible for organ allocation, also considers this as an emergency, and there is a super urgent listing for these patients. So any patient who was all right, did not have any liver disease, acute liver failure is an emergency, and even for organ donation, organ allocation, these patients are considered as super urgent, and they will supersede the list. They would be given priority all over the world, even in India, and rightly so. Because as I said, these may die within a few days. Then there is the big spectrum of a chronic liver disease. As I said, once they develop a complication, a clinical complication like ascites and encephalopathy, or if the MELD score. So we are living in an objective world. Everything has to be on the click of the phone, click of a laptop. So similarly, even medicine is moving towards that. We need objective criteria, which we can explain to our patients, explain to ourselves, explain our colleagues. So one of this is a MELD score, which is routinely used all over the world, model for end-stage liver disease. It takes into consideration 3 criteria: creatinine, prothrombin time, and albumin. And these three, and bilirubin, sorry. And these three criteria, a logarithmic analysis is done. It's there on your phone also. If the MELD score, it is a score between 6 to 40. If the score becomes more than 14, that is 15 or higher, then it becomes an indication. That means the liver reserve has gone low. So ascites may be there in the past, may have been well controlled, bleeding may or may not be variceal. So there may be some ambiguity over this subjective complication. But when there is an objective criteria, it is uniformly applied all over the world. And now, even in our city, our state, we have adopted MELD as the organ allocation criteria. So higher the MELD, sicker the patient will be given priority for organ donation. Why is MELD important? Definitely very important. If the MELD is 10, the 1 year survival is 90%. If the MELD is 30, the 1 year survival is 21%. So you see the drastic deterioration or the drop in mortality survival chances with the increase in MELD. So once the MELD is more than 25, it becomes a definite indication for an early transplant. And this is where the problem is. Average waiting period for organ donation, at least for liver, is 6 months to 1 year. If the MELD score is 25 and higher, 30 and higher, which lot of our patients are because they present late. If the MELD score is so high, the 1 year survival risk chances are only 20 to 40%. So if they do not get an organ within 6 months, there are very high chances, 3 in 4 chances that they will die. And that is where we need to increase the cadaveric organ pool so that these patients who come at that stage will get an organ. And the only option for them right now is a living related transplant. That is why 80 to 90% of the transplants in our country are all living related. Because the thing is, when the patient is fine, liver has a great reserve. And if the patient is doing well, he has a lower MELD, bilirubin is 2, 3, it is very difficult to convince the patient or even the referring doctor or the physician, surgeon that this patient needs a transplant. In our mind, we may understand that, okay, it's MELD is 15 today, it will progress. But what if it does not progress? And that is always the dilemma. So that is why most of the patients, either they wait, sometimes the treating doctors wait, sometimes we wait that, okay, he's been drinking, let him stop alcohol. He's been hepatitis B, let us treat hepatitis B. Autoimmune hepatitis, let us treat. But in that bargain, at times, the liver disease worsens, it progresses. And when they present at a stage where the MELD is more than 25, then they need an early transplant. And that is where the whole problem is. Then there is one whole spectrum of hepatocellular carcinoma. So liver transplant is actually the only curative modality of treatment for most hepatocellular carcinomas. So, but of course, they should be within the criteria. If they are very advanced, there is a higher risk of recurrence. So single lesion smaller than 5 centimeter or 3 or fewer lesions, with the largest being less than 3 centimeter. This is what we call as the Milan criteria. If the patients are falling within this, then the only curative and the best curative modality is a liver transplant. So one of those rare cancers where organ transplant is the treatment modality, is the curative option. If the patients are higher than these criteria, as in they have a higher, bigger tumor without any vascular invasion, without any systemic spread, then we can downsize them by doing chemoembolization, radiofrequency ablation. These are radiological procedures. Interventional radiologists go through a vessel into the tumor and inject drugs so that it will shrink the tumor. Once the tumor is shrunk to a size which comes within this Milan criteria, we can safely transplant. Having said that, if there is a vascular invasion or significant systemic spread, then it becomes only palliative care. So again, the importance is to pick them up early and get a transplant done. Many a times they are put on medicines, put on systemic chemo, and the time is gone and the patient and the disease spreads. So liver transplant is the curative modality for a lot of HCCs. So of course, there are contraindications. We cannot just transplant anyone and everyone. If the MELD is low, then we wait. Because again, the survival chances are 90% 1 year. the risk of transplant is also 10%. So there are patients who are the other end of the spectrum. They say, doctor, you know it's cirrhosis, you know it's not going to reverse, it's not going to be cured. Why not get a transplant now when I'm absolutely fit, when the MELD is low? The answer to that question is, when the MELD is low, you will survive 90% chances that you will be all right for the next 1 or 2 years. The risk of transplant is 5 to 10% in the next 1 or 2 years. So we do not want to offer a therapy which would have a higher risk than the natural disease history of the disease. So that's the dilemma we face sometimes. But we keep them on a close watch every 2 months, 3 months, and then follow up with the MELD score. Of course, a severe cardiac or pulmonary disease, AIDS is no longer a contraindication, but one of the factors we need to consider in looking at the overall fitness. Ongoing alcohol or illicit substance abuse, if the patient is still not going to stop alcohol, we would avoid a transplant. As I said, carcinoma which is spread, uncontrolled sepsis, active sepsis is a contraindication. If we can control the sepsis by 72 to 96 hours of antibiotics, we can take. And then, of course, there are anatomic abnormalities which we take. In the setting of an acute liver failure, if the intracranial pressures are very high, or the patient is having significant brain injury or coning, then we should avoid a transplant, because these patients will never come out of their neurological coma. Hemangiosarcoma is a contraindication, persistent non-compliance. So a patient needs a medically needs a transplant, but if there is no social support, patient is non-compliant, psychologically he is not geared up to take care of himself, or the family is not geared to take care of himself, then we should avoid a transplant. We have to understand transplant is not only a medical challenge. It is a social, psychosocial, financial, economic, and actually I would say in a way it is something where a society will have to play a role. So it's a very complex challenge which we all have to face. And that is why any good transplant program would have very dedicated coordinators. They would have dedicated psychiatrists, psychologists, the same psychiatrist who knows the in and out of transplant with whom we interact. And they can understand the requirements from a recipient, from a donor, from the family of the recipient. And these are very important issues. Pre-transplant workup is very exhaustive. We always do all the serologies for other infections, all the tumor markers. We want to look at the proper volume of the liver, the anatomical abnormalities, if there are any, the vasculature, the biliary. So this is something exhaustive. Now coming to the types of liver transplantation. There are two, we all know that. So there is a cadaveric liver transplantation and a living donor liver transplantation. Now, what are the pros and cons of each? The wait list period in cadaveric is at least 6 months. I would say at least 6 months. It may have been a little lower, but with COVID, the organ donations have gone a little lower. 6 months, at times 1 year. In living donor, there is no waiting period. So we can optimize the patient. When the patient is in a good physical condition, we can consider a transplant. So the advantage is the doctors or the medical team has he is in charge of when to transplant or when not to transplant. For a cadaveric, if the patient has not been following up for 2 months, suddenly an organ is available, we see the patient, he may be having some uncontrolled infection, some untreated infection, and we may have to, it becomes a little risky affair wherein we may have, if it's a relative contraindication, then the outcome may not be good. Organ quality is more predictable in a living donor because the donor undergoes a battery of tests to find out the quality of organ, the volume of the organ, and the anatomical issues. In cadaveric, the organ quality is predictable to a lesser degree. Having said that, in cadaveric, we get a whole organ, so that's advantageous. In living donor, there is always a volume mismatch, which may happen, which does happen in patients. But now, with transplant evolving and becoming more an absolute reality, we have stretched the boundaries and found that lower volumes may also be good enough. But it is still a risk. A small for size syndrome or a smaller liver may be a problem for the recipient, and that problem is not there in a cadaveric organ. Definitely, cadaveric is the best option if it is available, and especially in those if a living donor is not available. But if the patient is very sick and patient will die in the next few days or months, and if there is no cadavers, and living donor is the only option. Donor risk is minimal, but it is still there. We cannot deny that. It's not zero. And finally, if we want to move towards zero donor risk, we have to move towards a cadaveric transplant in the future. What are the goals of retrieval? So when our team goes to look at the liver, of course, we look at the organ quality, and the most important is the fat. So any fat which is more than 50% or more than 30% becomes a relative contraindication, more than 60% fat. So it's one is by visual inspection. The surgical teams are now, expert surgical teams can actually just visualize the organ and decide how much is a macroscopic fat deposition. At times when we are not very sure, we do a frozen biopsy of the cadaveric organ and see the amount of fat deposition in that biopsy. If it is up to 30%, we accept, of course, looking at all the other parameters. So this is a very complex matching we have to do. At times when the organ is not very good, but the patient is stable, we would want to take that risk because the patient who is stable may actually tolerate those physiological storms, which may come with a marginal donor, what we call them. But many a times, the patient who is higher on the list is also the sicker patient. So that becomes a dilemma. If it is a marginal donor, whether to give it to the sicker patient, because the whole argument is that if he does not get this organ, he may not survive till he gets another organ. So it's a very complex clinical discussion which happens between the team members, and we take a call. At times it pays off very well most of the times, but sometimes we have also had medical problems because of a marginal donor. But that's a risk all over the world which comes with deciding on a cadaveric organ. We are not going to get 100% perfect organ all the time. If the cadaveric organ is a 60-year-old, 70-year-old, he's had some kind of uncontrolled diabetes, sepsis, so the organ does become a little marginal, and that is something which we need to take into consideration. Then we perfuse this solid organ with cold preservative solution, minimizing ischemic hypoxic damage and optimize usability of all organs. And then, as I told you, it's transported in the solution, a preservative solution, to the center where the transplant is going to happen. When it comes to a living donor liver transplant, we need a donor who is between 18 and 55, blood group compatible, though ABO incompatible transplant is becoming more and more reality, but they have an added risk. So we'll not go into that. But age 18 to 55, blood group compatible, BMI less than 30 is the ideal donor for a living donor. They should obviously not have any viral hepatitis markers positive. And if there is the donor, we do a detailed vascular and volume assessment because it's very, very, very important for the donor safety. So if the vascular assessment is not proper, the volume assessment is not proper, we may have problems with the donor. So there should be a sufficient volume for the donor and for the recipient. And of course, we look at the biliary tree because those are the ducts where we are going to anastomose. So this is just a slide on the pre-op evaluation. We look at what we call as the graft recipient weight ratio. So how much liver comes out from the donor and goes into the recipient, that volume which goes into the recipient should be at least 0.8%. But this was actually the old data. Now we are accepting even up to 0.65, 0.7. But again, as a thumb rule, the GRWR should be 0.8% and at least 30% remnant should remain in the donor. Less than 30% is a high risk for the donor. So that we generally avoid. So at least 30% remnant in the donor and at least a volume which would be 0.8% of the body weight of the recipient. That is the thumb rule when we look at the donor. So this is just a cartoon showing the living donor liver transplant, wherein we see that it's almost 70% of the, so it's mainly the right lobe hepatectomy. The donor is left at times with the left lobe. The middle hepatic vein is kept with the donor in most of the centers, but these are again technical things which varies from center to center. So what are the problems for the donor? There is a risk of biliary complication. Importantly, the risk of death is very low. It's less than 0.3%. The mean ICU stay is 1 to 2 days, and most donors are discharged within a week. And that is in our center, in most successful centers where liver transplant numbers are good. So here again, the numbers, how well tuned the team is, the numbers really do matter. If you are doing 1 in a month, obviously these things are not completely ironed out. Biliary complications is 6%. Usually they are manageable. Many a times just medical conservative management at times needs ERCP or drainage of the biliary system. Death is very low, fortunately, but it is still there. It is not 0%, and that is something we still have to remember. Recipient issues. So 10% is a mortality overall in the 1 year. Most centers, most successful centers. If it is less than that, then there should be an audit of the center per se. 5-year survival of 80%, 1 year survival of 90% in most successful centers in transplant. And once they survive 5 years, then they would live a normal life and they would mostly die of other cardiovascular problem rather than a liver related problem. So what are the issues? What happens to the recipient which can threaten their life or the organ? So these are the usual issues. Common problems are again because of the immunosuppression, diabetes, osteoporosis, obesity, hypertension. These are all related to the immunosuppression. Then of course, risk of infection. In the first week, we usually look at vascular complications like hepatic artery or a portal vein thrombosis. Infections, of course, because these patients are sick. They have undergone a major surgery. Let me tell you, one of the most complex surgery is a liver transplant because the patients are very sick. Unlike in a kidney transplant where the patients can be optimized on a regular dialysis, we do not have something like a liver dialysis which can optimize or keep the patient stable. And that is why they are very sick. And when they are sick and immunosuppressed, there's the risk of infection. So we are not so much worried about rejection like in kidney transplant. We are more worried about the infections which would kill our patients because they are very susceptible and very high risk for severe sepsis. Acute cellular rejection, though the numbers are high, but they are very easily treatable, usually do not threaten the organ or life of the patient. Infection, again, as I said, in the first month, it's a bacterial infection. Second month onwards, there is a risk of CMV viral infections because of immunosuppression. Biliary complications are there in almost 15 to 20% of recipients, which we have to treat. So as I said, these patients are sick. The biliary anatomy at times, especially in the living related transplant, the biliary issues are higher because we may not get, we have to look at the donor also when we get out the bile duct, and also those issues lead to biliary complications. Then of course, disease recurrence. So like hepatitis B, hepatitis C, these are viruses which can come in the new liver. But now all these are taken care of very easily. We have fantastic antivirals for hepatitis B. We have a cure for hepatitis C. So we are not worried. What we are worried is the NASH. The commonest indication nowadays is fatty liver related, NASH related, and the recurrence of NASH is the biggest problem in our transplant settings nowadays. HCC, if we select the patients well, the recurrence rates are less than 10%. Alcohol recidivism is another big factor which we need to look into. So if you look at what are the causes of death post-transplant, this is it. Operative causes are 4%. The other cardiovascular, because a lot of these patients have diabetes, they have NASH-related liver disease, they have some cardiac issues, cerebrovascular issues. Infections is there in 20%. So the biggest killer is infection. That is why we need a dedicated liver ICU, dedicated liver transplant ICU, so that these are minimized. And the people who are looking after these patients need to be highly qualified in minimizing the risk of infection. Next 3 to 4 minutes, I'm well on time. I would just look at what is the cadaver transplant scene in India. So in the past 10 years, approximately 1,000 cadaver organ, maybe numbers, maybe a little bit 10 to 20% here and there. But initially almost 40% were done in Tamil Nadu. Now India is in Maharashtra has also reached that level, but it's mainly just 2 or 3 states which are driving the cadaver transplant scene. And if you look at the organ donation in 2015, this may have changed now, but this was the data I could get. It was Tamil Nadu where the number of donors were 155, Maharashtra is 60, which is still almost the same. So it had increased to maybe 70, 80. Again, it has come down to 50, 60. So Tamil Nadu, in fact, has also gone down. So the administrative will makes a huge difference in the number of organs. So these are total organs are what 1600 transplant in 2015, which is minuscule when we look at our population and our patient volume which needs a liver transplant. So it's like very, very low. And as you see, only 2 or 3 organs. So Kerala also, there were some issues. So the cadaveric transplant was halted. So I don't know what is the current situation in Kerala, but it's Tamil Nadu, Maharashtra, Andhra Pradesh, just 2 or 3 states which are driving the transplant. So out of this 1600 also, 3 or 4 states account for almost 80%. So India is doing dismally when it comes to organ donation. If you look at the current organ donation rate in India is only 0.05 per million population. And if we look at the cadaver rates in the Western countries, it's almost 15 to 20 per million population. So we are 1/100th of, or even lesser than that, of the Western countries. So when we have to become a developed country, this will be one of the huge factors, medical. So if we look at, if we have, even if from 0.05, we don't reach the 15 to 20 per million cadaver organ rate. But even if we can go up to 1 per million donation, even if it increases 20 times, we would have 1100 livers, which would take care of almost 40 to 50% of our demand. So we don't have to reach the Western standards. But if the cadaver donors increase, then we can still have, even if they increase to 1 per million population, we will have a significant number. If we look at the comparison between the cadaveric versus living donor, there is no comparison. If there are almost 10 times more living donor related transplant, then so this is mind you, this is the Western data where it is the cadaveric which is 10 times, but in India it is the other way. This graph is the other way. So again, why donate? We all know that one donor can be a resource for 11 patients. One donor can save up to 8 lives. And if we look at the Indian perspective, these are the problems which we need to take into consideration. There is shortage of organs. That's the first thing. Lack of awareness in doctors, in the intensivists, in the ICUs. At times, we just focus on the big hospital, 4 or 5 hospitals in the city, but there are hundreds of ICUs in smaller centers. So we need to make them aware of brain death, organ donation. There's a lack of trust. There's still a lot of administrative hassles which patients have to go. Cost of maintaining the cadaver, who will bear that cost? Whether it will be the society or the patient, that's still an unanswered question. The learning curve, again, to maintain an organ, use them, we need to train the doctors, the staff, the paramedicals, and then of course network and organization, because it cannot happen. And that is where administrative bodies like ZPCC play a very, very important role, because they have to organize and allocate the organs well and distribute them well. So to summarize, liver transplantation is the only curative modality for most ALF and for significantly decompensated liver disease and early HCC. Pre-operative evaluation optimization is very important for good post-operative results. So we need to time the transplant very well. Living donor is the mainstay in India because there is a huge requirement of increasing cadaveric pool. And long-term management needs multidisciplinary care, because we will need the metabolic doctors, the endocrinologists, the physicians to take care of all the problems which come with immunosuppression. And there has to be a special attention to recurrence of original disease. Thank you.
Thank you so much, Dr. Amit, for that wonderful talk on liver donor and liver transplantation. I hope all the learned listeners must be having a lot of questions to ask to you, which we will take at the end of the all sessions.
Okay, end of
Thank
this.
you. Yeah,
Okay.
thank you so much again. And now I would like to invite Dr. Ashwini, who is the next Master of Ceremony for the next half of the webinar. She is a Managing Committee member and also a pediatrician. So Dr. Ashwini can take over from here. Thank you.
Thank you. A very good morning. I hope I'm audible clearly.
Yes, you are.
Yeah, thank you, Dr. Ganesh, and thank you, the esteemed AMC members, President, Secretary, all the office bearers, the program committee, PCC, and the convener, and esteemed panelists we have today. We have been listening each session, and they are really insightful. Though I also am heading a big corporate organization wherein we do a lot of transplants. I had the medical administration part wherein we do a lot of transplants, but yet these sessions were very useful. Even I could note down many points. So, and on a Sunday morning, wherein we are committed now for the organ donation, we should take this forward on a long way. I agree that many of our office bearers says that even the panelists said that only corporate hospital are behind. As AMC, we have a huge potential. We have a huge connect with the patients and the relatives. So we should all collectively go forward, and this year should be a great drive for organ donation drive. अव्यय ध्यान से बढ़कर कुछ नहीं है. कुछ पंक्ति अगर आपकी इजाजत हो तो मैं सुनाती हूँ. मृत्यु के राह में ए मुसाफिर, सिर्फ दो रास्ते हैं सामने, एक अनजान अंधेरे में और एक अंगदान उजाले में. ये अवधान जो है इसका बहुत ज्यादा महत्व है. With this small note, I would now like to introduce our esteemed panelists today, Dr. Girish Trivedi. So we just caught him right now. Dr. Sunil Keswan is busy in some OT procedure. So we trouble Dr. Girish. He himself has just now come from an eye donation. That's the noble work which sir is doing. So Dr. Girish is a family physician. He is founder of AIDS Combat International, an NGO which is supporting people who are in need of medical help. He has been doing regular awareness talks on eye, skin, and organ donation for all the sectors of the society since last 12 years. So Girish sir, I would like this to take it forward and please enlighten us. Thank you, sir.
First of all, thanks a lot for inviting me to speak on a very important topic. And it's not only we all doctors have a very important role to play, but all the people who are committed for the cause, they can play a very vital role in increasing the number of eye donation and skin donations. I will be basically speaking on eye donation because this is one of the simplest donation which can be done. As you all know, a lot of people in India are corneally blind. If you look at the figures, out of the blind people throughout the world, 25% of the people corneally blind are in India. And unfortunately, many of these are young people, children who are having corneal blindness. And if these people are to get sight, somebody will have to do eye donation. We will have to get the cornea, and these people will require a cornea transplant, and these people will be able to see. So creating awareness is the most important thing. And then motivating the families to do eye donation. We all know about eye donation. आँखों का दान होना चाहिए, 6 घंटे के अंदर होना चाहिए. But when it comes to real donation, we miss out the cause. And during this COVID period, the eye donation number dropped dramatically. As such, the demand was very high, but COVID created a lot of problems. People were scared to do eye donation. Family was also not interested. And COVID protocol, there were a lot of other protocols. So the numbers dropped down drastically. And again, fortunately, the numbers are picking up. But as I told you, the demand is so high, the supply is on the lesser side. So we have to decrease this gap. And this can be done only by doing regular awareness programs. So this is a very good initiative taken by all Medical Consultants Association. I will just brief you about eye donation. Eye donation has to be done within 6 to 8 hours of death. So the moment the family is willing for eye donation, they have to contact the nearest eye bank. Now, I will just talk about the western suburbs. We have a eye bank in Borivali, Rotary Eye Bank of Borivali. So the moment the family is willing to do eye donation, somebody has to contact the eye bank that the family is willing to do eye donation. So the eye bank will send the team to the residence of the person who is expired, or if he has expired in the hospital, the team will go to the hospital. So this is the most important thing. The 6 hours period is also important, and you have to contact the nearest eye bank. Now, the moment you contact the eye bank, they will tell that you send the death certificate copy. So you have to get the copy on the WhatsApp and send it to the eye bank. They will go through the death certificate copy. If it is all normal, yes, person is not having any contraindication like septicemia or metastasis, end stage of cancer, hepatitis C, HIV, all things are normal, then the team will they will attend the call as early as possible. So death certificate remains to be the most important thing which is to be obtained as early as possible. Now, this is the problem we face. Many times the person dies, suppose the person dies at 2 a.m. at night. And if the family doesn't get the death certificate in time, then we lose a lot of eye donation calls. So you have to explain the family physician, the general family doctor, that you prepare the death certificate as early as possible. Because without that, neither the eye bank team will proceed, or the skin bank also the same things are required. So death certificate is very important. Once the death certificate is obtained, the eye bank people, the team of doctors, technicians, they will go to the person's place. They will tell the family to sign a simple consent form, where the nearest family member has to give the consent for that we are willing for eye donation. And it hardly takes 15 to 20 minutes to remove both the eyeballs. After removing the eyeballs, we place cotton plastic lids, so there is no disfigurement. When you are taking the body for cremation, there that time also there is no problem. Minimum bleeding is there, and we request the family member that before the team comes, they have to take certain precautions, like they have to raise the head by putting a small pillow, put off the fan. If the AC facility is there, they should put on the AC, and they should place wet cotton or wet cloth on the eyes after closing the eyelids. So these are certain things they have to keep in mind. As I told you, it hardly takes 15 to 20 minutes to remove both the eyeballs. Once the eyeballs are removed, they are sent to the eye bank, and within 96 hours, the cornea processing is done. The cornea is removed from the eyeball. It is processed, and if the cornea is good, then the eye bank people will immediately phone the family members of the people who have registered the name of the corneally blind people with the eye bank. And they will take the cornea. They will go to a cornea transplant surgeon. A keratoplasty will be performed, that is cornea transplant. And within 96 hours, the thing which we were going to burn or bury will give sight to two corneally blind people. So this is very simple. If the family is willing, they have to contact the eye bank, certain precautions to be taken. Death certificate is very important. It has to be sent to the eye bank. Now, there are a lot of misconceptions. People think that मोती बिंदु का ऑपरेशन हुआ तो आंखों का दान नहीं होगा. That is wrong. Cataract, people who are operated for cataract, they can do eye donation. The family can do eye donation. People who are having diabetes, who are having high blood pressure, these all people's eye can be donated. And age limit is we can donate eyes from 1 month to 80 years. We take eyes after 80 years also, but after 80 years, many times the cornea, the condition of the quality of the cornea is not so good. So that cornea or eyeball can be used for therapeutic purpose. But young death, the cornea, 100% it will be good and it will be used for transplant. So these are things which we all have to keep in mind. Creating awareness remains the most important parts. creating awareness for the doctors, because a family doctor can easily convince the family members for doing eye donation. So the family doctor's role is very important in promoting eye donation. In a city like Mumbai, we require almost 25,000 corneas a year, and we hardly get 4 to 4,500 corneas. So we have to increase the number of eye donations, and this is by doing regular programs. And doctors have a very important role. I request all of you to at least tell the family about eye donation and skin donation, because these two donations can be done once the person is declared dead. After natural death, if the person is brain dead, you can do a lot of other organ donation also. But after death, these are two very simple donations. So this is in simple, I have explained about eye donation. We will have whatever queries are there, we can just clear the queries. Hello.
Yes, sir. Sir, thanks a lot for the valuable insights. Indeed, yes, we can contribute in a large way. As you said, there are two sectors, brain dead organs. After the brain death, we can retrieve many organs, and for the eye, it is very, very easy. And you give a lot of inputs, sir. We have noted all the inputs. So question answers will be taken at the end. So, sir, we request if you could stay.
Just a small point. We had some message there. We have a technician who is trained, and Rotary Club of Bombay West. They are doing fantastic work. Whenever we get a call, we just coordinate with the coordinators, so we don't miss out a single call. If the call is at Virar or it is at Thane, we do all the calls. So there are a lot of things which can be done by training a technician, by starting collection centers. So these are things which we can start doing at a bigger level.
Yeah, Dr. Girish and Dr. Manoj Patel, I'm an immediate past president of Rotary Bombay West. We have that Rotary Eye Donation Center that we are running successfully, and the technician goes to even major hospitals.
I have sent at least 40 donations through Uttam.
Yeah, so Uttam is our technician, and we are doing it regularly. And now we have sent it for also.
Yes,
so
yes,
we'll be planning to do that also.
Yes, very nice, very nice.
So we appreciate the silent workers.
If someone could put the contact number of these people in the chat box, then the attendees can get that contact number right away.
Okay.
I will put it right now.
We really appreciate the silent workers. This was never enforced. We should really appreciate. And yeah, as Dr. Nilima said, if you could get the contact number, it will be easy for us to float. So Dr. Girish sir, any more input, sir, or should we proceed?
I think I made it very simple. Everybody has a role to play. And I think we should do more and more awareness programs for the medical practitioners, because this is from where we will be getting a lot of eye donation and skin donation and even organ donation calls.
Yes, sir. Sure. Thank you, sir. Thank you, Dr. Girish. And now we proceed to our next session. So here we have a stalwart, Dr. Sunil Keswani. Good morning, sir. I've been personally his resident also. We have seen the phenomenal work what sir has done. He is a plastic, cosmetic and burn surgeon, past president of Indian Medical Association. Dr. Keswani is district officer of Rotary District, ex-regional representative for Southeast Asia for ISBI. He is having several publications in burns in reputed journals in India and abroad. So we know the phenomenal work, sir, you have been doing in day and night. With this, we would like you, sir, to enlighten us and the entire AMC members here, sir.
Can I share my screen now?
Yes, sir. Yes, sir.
Perfect. Can you see my screen?
Yes, sir, we can see.
Has the skin banking in India slide come in?
Yeah, it's come. If you could go on a slideshow, sir.
Yeah, I'll go on to slideshow. Yeah,
Yes,
perfect.
sir. Yeah.
Just wanted to cross check.
Yes, yes. Yes, perfectly seen, sir. Go ahead.
Okay. A very good morning to you all, friends. And it's indeed a pleasure to be addressing such a well-known and efficient organization, Association of Medical Consultants. I'm extremely proud of being such a member of such an association. Whenever I go out of Bombay, I talk about our association, the kind of facilities that it gives its members and supports them in terms of times of crisis, and creates so much awareness in the forms of various continuing medical education programs that our association does. So long live Association of Medical Consultants, and all the very best to you. First of all, I must like to thank the office bearers of this association for having me here, Dr. Nilima, Dr. Hemant, Dr. Reena, Dr. Manoj Patel, and of course, Ashwini, Dr. Ashwini, for having introduced me. Most of us know about eye donation, we know about blood donation, we know about organ donation, but very few people, including doctors, are aware that skin is also an organ or tissue which can be donated. India, with its vast cultural heritage, a whole lot of rituals, traditions, and culture, has lots of myths and false beliefs regarding organ donation. And I think the previous speakers have done great justice to this whole thing. Talking about skin donation, essentially the skin is utilized maximum in case of burns, because burns creates large raw areas which need to be resurfaced. The only way to resurface these large raw areas is to put skin from somebody else initially, and then skin from the person himself. Skin from somebody else is known as an allograft, or cadaveric skin from the skin bank, and skin from the person himself is known as an autograft. India, with a population of almost 138 crores as per the last census of 2020, we record about 70 lakh burn injury cases annually, of which 1.4 lakh people die every year. 50% of these, that means almost 70,000, could have been saved if there were enough skin banks and enough skin donors. In India, 70% of all burn injuries occur in the most productive age group, that's 15 to 35, unlike in the West, where majority of burns occur either in small children or in the elderly above 75. In India, around 4 to 5 burn cases are women and children, and as many as 80% of cases admitted are kitchen-related accidents. What is skin bank? Basically, skin banking is a facility where the skin is collected from eligible deceased donors and processed as per international protocols, which can be used to resurface wounds. The international protocol that we follow in India is the Euro Tissue Bank protocol from the Euro Tissue Bank, which is based in Amsterdam, a place called Beverwijk, near Amsterdam. Skin, ladies and gentlemen, is a tissue which can be stored in the skin bank at 85%, at 4 to 8 degrees centigrade in 85% glycerol up to 5 years. Now, how many skin banks do we have essentially? In Maharashtra, we have 6 skin banks and 2 collection centers. In Karnataka, 2 skin banks. In Odisha, 1 skin bank. In Tamil Nadu, 5 skin banks. Madhya Pradesh, 1 skin bank. In Haryana, 1 skin bank. I can very proudly say that the National Burn Center and Rotary Club of Bombay North Skin Bank, which is the club which supported us for the skin bank, have set up 12 of these 16 skin banks, along with Rotary. Now, in India, we preserve the skin in glycerol. Abroad, in the USA, they store the skin in a cryo medium and at minus 196 degrees centigrade in liquid nitrogen. But in India and Europe and in the Indian subcontinent and Southeast Asia, glycerol is the preferred technique of preservation. Why is glycerol preferred? Because easily available in India. It's cost effective for the Indian subcontinent. There's an ease of transportation. Skin can be transferred in glycerol from Mumbai to Tamil Nadu, from Mumbai to Kashmir. So we have been transporting skin elsewhere through the courier services, which are specially licensed to transport live tissue. Again, glycerol has less antigenicity and maintains extracellular matrix and the elastin fibers. What is the effectiveness of glycerol? Basically, it's a cryoprotectant, it's a decontaminant, it's a good preservative, and non-toxic. How do you organize the skin? How is the skin donation program organized in India? Essentially, how organ donation program is organized. Essentially, there is a body at the apex that's based in Delhi, that's National Organ and Tissue Transplantation Organization, essentially called as NATO. Then it is divided into 5 regions: North, South, East, West, and Central, which is called ROTO. There are 5 ROTOs. And of course, there are SOTO, that's State Organ and Tissue Transplantation Organization. India has 29 states, as all of you know, so there are 29 SOTOs. And in Mumbai, the distribution and documentation for the organs, the waiting list, etc., is maintained by Zonal Transplant Coordination Center, also known as ZTCC, whose office is based in the Sion Hospital or LTMGH Medical College. Now, this is how the whole network goes. We will not go into that. Now, these are the partner clubs which helped us set up our skin bank at the National Burn Center, the Rotary Club of Bombay North Skin Bank. We had a partnership from Rotary Club of Leiden in Amsterdam. Rotary Club of Bombay North is the sponsoring club, and Euro Tissue Bank in near Amsterdam is the one which supported us and transferred the technology and SOPs to us, as a result of which we follow their protocols, and our protocols are internationally accepted protocols. This is the infrastructure of the skin bank. This is the administrative office, very important because documentation plays a very, very key role. When the skin was taken, from whom the skin was taken, who did the processing, who distributed the thing, so that at any point in time there is a infection or something goes wrong, we can trace back, okay, where did we go wrong. This is the cold room. This is the outer view of the cold room that you see out here. This is a skin processing room. This is a kit storage room. What you see here on the rack are, at any given time, 6 kits are ready for us. And we have the capacity to service four calls at the same time. This is the biosafety cabinet where processing is done. Maintains the sterility during the skin processing. The processing is done inside the sterile atmosphere. This is the incubator where the skin is allowed to mix with the glycerol to percolate inside and at 55% and then 85% later on. This is the hot air oven for sterilizing the instruments. The incubator, this is the cold room. This is the actual walk-in fridge where the skin is stored in polycarbonate containers, each strip in a separate container, labeled properly how many square centimeters it is. So essentially, it consists of these various things. First of all, the call comes on the helpline. The person at the end of the helpline, it's a 24/7 helpline available at all times. It's 2779-3333, 2779-3333. Once the call goes, a few questions are asked. What time did the death happen? What was the cause of death? Is there any contraindication to the donation? And once that it's decided, yes, that we can go ahead, there's no contraindication. We are still within the window period of 6 to 8 hours. Then our team leaves within 20 minutes from the time of receiving the call. Then the skin is harvested either at home or in the hospital where the person has died. This skin is then transported to the skin bank. We have specialized skin bank ambulance for the same purpose. This skin processed, there's a phase 1 processing, there's a phase 2 processing and a phase 3 processing. The whole processing phase lasts for 45 days. The skin which we received today is ready for distribution and use only on the 46th day. The storage and documentation is done by the skin bank officers. We have 8 skin bank officers. This is distributed after checking the antecedents of the one who has asked for it. We try to prevent any middlemen coming into the picture. Documentation is very important, and quality control. We have both internal and external audits happening to maintain quality control. So first of all, when the team goes to the bank, to the site, home or hospital where the person has died, again, a consent is taken from next of kin, even if you're pledged that your skin has to be donated. A sample of blood is taken either from the femoral vein, or if that is thrombosed already and the call has come late, we take it from the heart with an intracardiac needle. The body is cleaned properly, like in a surgical procedure with beta scrub. Then the skin is harvested with the help of dermatome. The body is dressed after harvesting. The harvested skin is preserved initially in 50-55% glycerol, then later on transferred to 85% glycerol. This is the phase 2 happening, kept under shaking incubator for percolation of the glycerol into the skin. The skin dimensions are measured with ruler scale. The skin is meshed 2:1. Some skin is kept unmeshed because in certain technical conditions you need unmeshed skin, but by and large everyone needs meshed skin. So measuring is done 2:1 by a special instrument known as a mesher, that's a Brennan mesher. And each strip of skin having measured, if they say is 15 by 10 centimeters, then we know that there is 150 square centimeters of skin in that particular container. Microbiological tests are done both for aerobic, anaerobic bacteria and for fungi. Then this is distribution. The courier person comes, it's kept in a ice box with in a cold atmosphere and transferred with ice packs. So this is how the whole thing goes. The call received at the center, the team gets ready, the kits recheck, the team leaves in the specialized ambulance from the center within 20 minutes. So it's divided into 4 stages. The receiving the call, the harvesting of the skin, that's retrieval, processing of the skin, 3 phases, 45 days, storage in 85% glycerol at 4 to 8 degrees centigrade. Skin can be stored for up to 5 years, and distribution It can be in Bombay or Pune or Tamil Nadu or anywhere in the country, wherever the courier service is functioning. So this is again the procedure of cleaning going on, measurement. We just repeat the whole thing in one slide. And these are the statistics. We started in 2009. We used to get 2 donations a month. That's worked out to about 24 donations a year. And we reached almost 200 donations in 2016-17. So that has been the maximum. We was in 2014-15, we had touched 261 donations. COVID brought the numbers down and we are again getting back to normal. So averagely, we harvest about 20 donors' skin every month, roughly, amounting to about 200, 170, 80, 200 donations a year. Now, 20 donations are not adequate. We have 2 other skin banks in Mumbai at the Masina Hospital and at the Sion Hospital. And collectively, we collect about 30 donations a month. But Mumbai city requires about 300 donations a month. We are falling short by about 270 donations. That means 270 people are not doing well or either dying or becoming severely morbid due to lack of skin. I think the need for awareness, Dr. Girish Trivedi has stressed upon. I think there's only one way to get more and more skin donations. It's awareness, awareness, and more awareness. So this is a case which we show how the skin is helpful on admission. This is a 40% burn in a 14-year-old child, or a 14-year-old student who was to appear for an SSC exam. He came on the 3rd day, we excised the dead skin. Once you excise the dead skin, chance of infection go down. He was not in a fit condition to take his own skin, so we took skin from the bank. It's known as allograft or a cadaveric skin. He healed up in 2 weeks' time and was discharged. He could appear for his exam and then pass. Same thing on the upper extremity. It was excised within the first 48, 72 hours, and he could appear for his exam and pass with 85% marks. There's another patient in industrial burn, back burns about 25%, back and the legs were burned. He harvested, excised the skin by the 3rd day, put allografts. He healed uneventfully without much scarification. Some hypopigmentation did persist, but over a period of time that goes away. And by 3 years, at the end of 2 or 3 years' time, even the pigmentation comes back. Of course, the color is not absolutely normal, but it's almost near normal. And point is there is no deformity, minimum cost, patient goes home early, no chance of getting infected. So this skin plays a human's role in saving the life of such patients. Now you might ask, where all do we send this, are sending this skin from our bank? We are sending it to in Maharashtra, Madhya Pradesh, Gujarat, Telangana, Karnataka, Kerala, Uttar Pradesh, West Bengal, Tamil Nadu, Delhi. But futuristically, we expect skin banks to be available at all these states, and where we need not send skin there, and they should be self-sufficient. So it's a matter of time before they become self-sufficient. It is our endeavor to set up banks in different parts of the country. We have been setting up 2 banks per year. The next 2 banks are likely to come up in Ahmedabad and Vadodara. These are skin bank statistics. In blue, you see the amount of skin procured. In red, you see the amount of skin used. It almost balances out. Jaise skin aati hai, wo khatam ho jati hai. On the 46th day, when the skin is ready, we already normally have 3-4 people already in the waiting list. And we have to kind of see who's more serious, who's more likely to survive, and then we give the skin. And there are various NGOs who have been helping us, the Sumati group, the Manavta group, the Sunday Friends from Jain Society, Matunga, Sion, the Sneha Bandhan Charitable Trust, the Federation of Body and Organ Donation, the Mohan Foundation, Associated Eye Bank. There are a lot of individual social workers. Mira is there, Bapte Kaka, Shripad Agashe. Ultimately, the successful donation happens when either the NGO or the transplant coordinator primes the relatives of one who is dead or dying on a ventilator, and the skin bank coordinator or transplant coordinator or the NGO coordinates with the relatives, and having done with the relatives, the donation then goes into place. Direct donations are few and far between. 80% of donations occur through NGOs or transplant coordinators in the city of Mumbai. And the whole lot of reasons why donations don't come in that large numbers. One, there are certain rituals that are to be performed after that. So many people want the rituals to get over, and then they say, "Can I be late? Ho gaya, donation nahi ho sakta hai." Cremation timings are another thing which clashes. Body preparation is required. Sometimes some communities have a little disbelief in the whole procedure. कि हम आप ये टाइम skin donation करोगे कि अगले जन्म में आप skin के बिना पैदा होगे. All kinds of disbeliefs are there. So it is for us as doctors and as healthcare workers to create more and more better awareness. Again, there is high traffic in Mumbai, and sometimes it is easier to reach Lonavala in about an hour's time, and it takes about 2 hours to reach Dahisar, which is in Bombay. That's the paradox of Mumbai, such a city. And floods during monsoon again create havoc. Our teams cannot reach there fast, very rapidly. But the key is the window period of 6 to 8 hours can be extended to about 12 hours. If you cover the body in a clean bed sheet and pour some water on it, saline or cold water, and keep ice on it, put the fan on, or keep the body in a mortuary under air conditioning, then the window period extends to 12 hours. So the skin can be harvested up to 12 hours. So some of the myths and disbeliefs: skin can be donated when I'm alive. No, normally when you're alive, you normally don't take the skin. It is after death. If I decide to donate my skin after I pass away, my body will be skinless and appear red and bloody after the donation. No, your body does not look red and bloody because there's no blood gets coagulated, and there is no distortion of the body's shape, size, or looks. And when you remove the skin, the full thickness of skin is not removed. Only if the skin has 8 layers, only the one layer, a wafer-thin layer is removed, and the wafer-thin layer does all the benefits that is required in the patient. Open casket funeral is not possible for skin donor. No, that's not. It's possible because the body is covered up. You can wear your clothes up, put on, and sometimes in some communities, even the jewelry is put on before the cremation or the burial. I am old, my skin is wrinkled. Even wrinkled skin is useful. Nothing wrong with histology. Skin gets wrinkled because of loss of muscle tone and loss of fat. That's why the skin is wrinkled. The oldest person whose skin we harvested was a 92-year-old from Lonavala, one Mr. Joshi, and his skin was used to save the life of an 18-year-old boy who had sustained burns while electrical burns while trying to take out a kite from a high-tension cable. Then my family will be charged money if I donate my skin. No, there are no charges. You don't have to pay the team any money for donating your skin. So skin cannot be bought or sold. So it has to be taken free and given free. There is a processing fee which is levied. Some people say my religion discourages organ and tissue donation. But my dear friends, no religion discourages organ and tissue donation, because when the religion started many, many years ago, 4-5 centuries or earlier ago, there was no organ donation happening. So there is no question of it's how you interpret your religion, how your religious leaders interpret the thing. So keep an open mind. If your body after death can save the lives of few people, why not? It is said that 8 people can benefit from your body being donated for organ donation. Why not? When you're alive, do help people. When you're dead, even continue helping people by donating your body. So during COVID times also, we were harvesting skin with checking the history, taking swabs, wearing proper protective equipment, personal protective equipment, masks, etc. And it is said the success of a functional skin bank largely depends on creating mass awareness about skin donation. Establishment of a state-of-the-art skin bank for producing consistent, high-quality allograft at a very affordable cost is the need of the hour. This requires significant manpower and financial transport, which Rotary is willing to give, and we at the National Burn Center and the Rotary Club of Bombay North Skin Bank are willing to give all the support to help you set up skin banks and help you with the awareness programs. We have a team of 10 people who are constantly giving talks. Anytime you fix up a talk, our team will be there with a laptop projector to give the talk. I think we have to associate with philanthropic NGOs like Rotary, who provide the funding, and NGOs who provide the donors. So I think it's very, very important to have a collaborative effort to do this whole thing. Apart from burns, this skin is used in diabetic ulcers. It is used on trophic ulcers. It can be used in exfoliative skin diseases like toxic epidermal necrolysis syndrome or epidermolysis bullosa. So there are lots of indications. It can be used in orthopedic trauma and degloving injuries. So there are lots of indications where the skin can be used apart from burns also. And the need is great, so that demand far outstrips the supply. There is a big need for skin donation, and we must have more and more people donating skin. So there were a lot of difficulties. Initially, it was very difficult to convince the government, the medical personnel for the need of skin banking. It was difficult to train the staff, but now we have crossed that hurdle. And the only thing which remains is the last point, creating mass awareness. We are creating awareness, but on a small scale. We need a much bigger effort to get people to be convinced and more people to know that skin can be donated. I always say that it's not that in India people do not want to donate skin and eyes. It's that they don't know that how to go about it. What's the helpline number? And when the death occurs, there's so much chaos. Then if you don't have an easily available helpline number where to call up, you'll say, abhi rehne do, abhi kahan se dhoondenge? Let us go ahead with the formalities, the rituals, and let's get the cremation done. All in all, as I schools, colleges, corporate offices, fire brigade, NCC cadets, NDA staff we have been doing, National Defense Academy staff, religious places we go and give talks through Rotary and otherwise, condolence meetings, international, national conference. Whenever there's a conference, ask for 5 minutes or 10 minutes of the time to talk about organ donation, skin donation, and eye donation. We do car rallies. Newspapers are always willing to put up some articles if you write them well and approach them well. Prime the medical person, hospitals, nursing home, and healthcare workers, the nurses, the physiotherapists, they ought to know about it. Do walkathons, do cyclothons for creating awareness. Small efforts, but ultimately little drops make an ocean. There are various awareness programs which we have been doing over the years. I'm sure Rotary has given us a lot of support, and we are part of Rotary and IMA, Indian Medical Association, have been helping us out. The various lectures we have given at various forums, educating NCC cadets at the Navy establishment, creating awareness in firefighters, condolence meetings. We have teams of people, groups like Sunday Friends and others who go and give talk. Our team goes and gives talks at condolence meetings if we are invited to prime the people about skin, eye, and organ donation. Various volunteers who come to the hospital are primed about donation. Car rallies are conducted for skin, eye, and organ donation. Various corporate offices, we go and give talks. Through the media, the various newspapers, and this is a walkathon which we recently organized at Carter Road. And essentially, it's a team effort. It's you and I. When we put our hands together, only then we'll get lots of skin donation, eye donation, and organ donation. And the dream is that no person in India should die for want of skin, eyes, or organ donation. Thank you, ladies and gentlemen.
Thank you, sir. It was really insightful. Would you still like to add something about awareness activities so that there are almost 210 participants, all doctors. Many are having a lot of very good practice. So we can also replicate that if you would like to talk about awareness.
We have got ready-made material available with us. We have standees available to us. We have various materials. So whenever you want, you just let us know. We will be able to provide you the standees. We'll be able to provide you the mailers. If you want your names to be printed on it, we could put your names printed on the standee or the mailer and provide it to you. So it's quite easy. There are small 1-minute videos which are available on WhatsApp to create awareness. I will share that with you, Dr. Ashwini, or with Dr. Dugard. And essentially, all the materials are ready. So once we send it to you, you have such a large membership list. If each of the member just tells 10 people about organ, skin, and eye donation, it will have a multiplier effect. It's very easy. At any function, at any CME that we conduct, if 5 minutes can be given, somebody can speak on, please donate skin, save a life, donate eye, save sight, donate your organs before death. But ये 20 seconds में हर बार बोलना चाहिए, because एक बार बोलने से कुछ नहीं होता है, बार बार होना चाहिए. Because English में एक कहावत है, knock and the door shall be opened to you. बाइबल में कहा गया, knock and the door shall be opened. तो किसी ने कहा अगर दरवाजा नहीं खुले तो क्या करना है? उसका corollary बनाया मैं, if you knock long enough and loud enough, you are sure to be heard. तो हमें दरवाजा खटखटाता रहना है, हमको कभी give up नहीं करना है, और ये persistence is the key to the success of any effort or project.
True, we agree, sir. जैसे कहते हैं, मुझे कुछ न मिला विरासत में, मुझे कुछ न मिला विरासत में, मुझे कुछ न मिला मोहब्बत में, पर इंसानियत के प्यार के लिए मैं अंग छोड़ रहा हूं विरासत में. सर, इसी के साथ हमारे AMC President Secretary, the esteemed Managing Committee of AMC has already started the great organ donation drive, and we would just like, as a source of inspiration, if we could just flash, you know, that when the leader starts, the entire karma chalne lagta hai. So we would just like the admin to just flash some of inspirational motives or gestures which our President, Secretary, the MCC, all are doing. Pranav, can we have those small slides, please? Yeah, here they are. So this speaks up for itself. We are all charged up. And as you rightly said, the President, the Secretary, the program, Dr. Ganesh here, Dr. Rima, we all are ready. And now, जैसे कह रहे हैं हम कारवान चलते जाएगा, everyone will follow. And with this, yes, we have started as a committee. You can start too. That's what Dr. Nilima wants to say. You want to add something, Dr. Nilima?
Absolutely, Ashwini. Thank you for giving me the chance. organ donation has been very, very close to my heart because a very, very dear friend had to hunt around for a lung transplant, and she reached America and she came back and she couldn't find lungs for herself. And that is a very big pinch and a pain to me. And I realized that we as doctors also do not have an idea of how to counsel. A lot of physicians meet patients who are, at absolutely the end of life. In AMC, we are also working on something called as the living will, where we are allowing patients to make a will as to when their ventilator should be switched off legally. I would want to volunteer over here saying that, we could take the initiative to even add the organ donation pledge in the similar will. Because a lot of times what happens, I may have donated and pledged to donate my organs. But once I am dead, then what? Will my relatives really consider my wish? Or do they have the right to veto my wish, which I have made? Because I have done the organ donation card, but I don't have anything in writing that, yes, my relatives will not have the right to veto my organ. So something like that legally has to come forward. I think AMC can also work legally in the way that where countries like Spain, like Rina just pointed out to us, that only negative consent is considered. And if you do not have a negative consent, it is considered that you are willing for organ donation. All right. So we as a committee have started, nearly 80% of my managing committee has already registered on the NOTO. They are waiting for their cards to come. It takes a little amount of time, and very, very shortly, the entire committee will be pledging their organs. This is a voluntary thing, so I cannot myself force anyone. But yes, I have started. I was the first person again in the committee to put up you all to do this. AMC will be giving you a certificate saying that you have pledged your organ, and you could print it and frame it and put it up in your consulting room. That will become an inspiration to your patients as well. Yare, mera doctor pledge kar raha hai, so even I can do it. And like Dr. Keswani said very aptly, we will be reiterating the organ donation awareness at every program possible up till now, whatever programs we've had, Dr. Keswani. Even for the blood donation, we have kept an organ donation placard and a selfie point, for people to come and be aware that there is something called organ donation. So thank you very much, and yes, we should be doing our best. Thank you.
Yeah, thanks, Dr. Nilima. Like we miss seeing the videos, so would now request Pranab to, can we have a look at the videos? And Dr. Shruti will be reciting a very nice poem, and then my colleague, Dr. Gyanesh, will take over the question and answer session, and I'll join you shortly. So over to the videos now.
परिणिता कन्स्ट्रक्शनचा हा प्रोजेक्ट आपण मुदतीत पूर्ण केल्याबद्दल कंपनीच्या वतीने मी तुमच्या सर्वांचं अभिनंदन करतो. थँक्यू सर. हा प्रोजेक्ट तुम्ही 7 जणांनी मिळून केला. आय मीन साक्षी तुमच्यासोबत नव्हती, तरी सुद्धा हा प्रोजेक्ट तुम्ही 6 महिन्यात कंप्लीट केलात. खरोखरच ही गोष्ट कौतुकास्पद आहे. यासाठी मी तुमचं मनापासून अभिनंदन करतो. थँक्यू सर. पण त्या नसतानाही गेल्या 6 महिन्यात तुम्ही त्यांची उणीव भरून काढली, हे कौतुकास्पद आहे. दॅट्स टीम स्पिरिट. यस सर. आता आपल्या हातात 2 मोठे प्रोजेक्ट आहेत. आपण त्याच्यावर वर्कआउट करूया. मिस्टर सुदेश, उद्या तुम्ही कोटेशन पाठवून द्या. ओके सर. ही जबाबदारी तुमच्यावर आहे. ओके सर. शीतल आणि सँडी, यस सर, तुम्ही दुसऱ्या प्रोजेक्टकडे लक्ष द्या. ओके. कुणाचा फोन आहे?
साक्षी मॅडमचा आहे सर. मलाही आला होता.
घ्या ना.
हॅलो मॅडम. हा बोला. कशा आहात तुम्ही?
मला काय धाड भरली आहे. आणि ती शीतल आली आहे का ऑफिसमध्ये?
हो, आल्यात.
मग माझा फोन नाही रिसीव्ह केला तिने.
मॅडम, आम्ही बोर्डरूम मध्ये आहोत.
कोण खडूस मीटिंग घेतोय का? सगळेच असाल ना आता आतमध्ये त्या खडूस सकट. असू दे, फोन स्पीकरवर टाक.
सर, फोन स्पीकरवर टाकायला सांगताय.
काय हरकत नाही.
अरे टाकलायस ना स्पीकरवर.
हो टाकलाय.
काय गे शीतल, माझा ऍक्सिडेंट झाल्यापासून एकदाही भेटायला आले नाहीस मला.
नाही मॅडम, आले होते पण तुम्ही कोमा. बरं झालं तुम्ही फोन केलात ते.
अरे हो, विसरलेच. ज्या कामासाठी फोन केला होता ते सांगायचं सोडून दुसरंच काहीतरी बडबडत बसले. ऐका, ऐकताय ना सगळे?
हो ऐकतोय.
उद्या संध्याकाळी आम्ही अक्षयचा वाढदिवस साजरा करणार आहोत.
अक्षय?
सगळ्यांनी यायचं.
पण मॅडम,
आता काय झालं?
नाही, येतो आम्ही, सगळेच येतो अक्षयच्या वाढदिवसासाठी.
ओके, बाय.
बाय.
बाय. कधी येणार परत तुम्ही?
अगं फक्त 5च दिवस. नशीब एवढी तरी सुट्टी मिळाली. आणि हो, त्या परिणिता कन्स्ट्रक्शनच्या कॉन्टॅक्टमध्ये राहा.
हो मॅडम, मी करते फॉलो.
तसं काही टेन्शन नाही ग, तू करशीलच. पण काही लागलं तर मला कॉल कर.
नक्की. चला मग, बाय. हॅपी जर्नी.
थँक्यू.
त्यांचा मुलगा कायमचा सोडून गेला त्यांना, आणि त्यातनं त्या अजूनही सावरलेल्या नाही.
आणि त्यात उद्या संध्याकाळी वाढदिवसाचं आमंत्रण. तुम्ही असं करा, तुम्ही दोघेही जण तिकडे जा, आणि काही गरज लागली तर तुम्ही मला कॉल करा.
शुअर.
अरे हो, अहो पडलो असतो ना मी. अरे काळजी करू नकोस, मी आहे ना.
थांब. या ना.
अरे ऑफिस मधलं फक्त तुम्ही दोघच? बाकीचे कुठे?
हा हो, म्हणजे एका नवीन प्रोजेक्टचं काम चालू होतं म्हणून मग आम्ही दोघे.
हा बसा ना.
तू कोल्ड्रिंक आण. हो आणतो.
साक्षी मॅडम
आहे ना. आत आहे. सकाळपासून तिची धावपळ सुरू आहे. क्षणभर सुद्धा बसली नाहीये ती. बाय द वे, हा माझा मावस भाऊ डॉक्टर अविनाश.
हॅलो.
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 एक्सक्यूज मी.
या शुअर.
साक्षी मॅडम बऱ्या आहेत ना?
बरी आहे. तिच्यासाठी सगळं चाललंय हे. बाय द वे, तुम्ही काय घेणार? चहा की थंड?
काही चालेल. हा.
एक्सक्यूज मी.
या शुअर.
ए बेबी फोटोग्राफर, इकडे ये.
हे हिरो, आमचंही काढ ना फोटो.
हो. रेडी?
वा, थँक्यू.
दाखव. छान काढलेस रे फोटो.
बघू बघू बघू. वा, मस्त चालाय रे. ग्रेट.
थँक्यू.
काय नाव तुझं?
अक्षय. तुम्ही बर्थडेला आलात ना?
हो.
मग गिफ्ट कुठे?
अरे गाडीत ठेवलाय. केक कटिंग झालं ना की देते.
नक्की ना?
हो नक्की.
मग स्माइल.
हो.
थँक्यू.
थँक्यू.
दत्तक घेतला असेल बहुधा.
हो, म्हणजे मलाही तसंच वाटतंय. आणि नावही अक्षयच ठेवलंय.
मिस शीतल, राईट? मिस्टर संदीप. सॉरी सँडी.
हो. ज्योतिषी ऍस्ट्रॉलॉजर आहेस का?
अहो नाही नाही, अभिनेता आहे. नाटक आणि सिरियल मध्ये काम करतो.
तरी काय नाव आपलं?
अक्षय. अहो सावकाश. एक्सक्यूज मी. अरे वेलकम वेलकम वेलकम. या 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 या. केक आहे? केक आहे? ब्लॅक फॉरेस्ट. नाही नाही नाही, चलो ये ये, चल.
सगळी तयारी झाली आहे ना?
झालीये.
हे बघ, माणसं इकडे येण्याच्या अगोदर आपली पूर्ण तयारी झाली पाहिजे.
सगळी तयारी झाली आहे, फक्त केक आणायचा.
केक मग जा ना, घेऊन ये ना लवकर. असं काय करतेस तू? आणि इकडे ठेवूया आपण.
हाय. हाय.
ए इकडे दे, इकडे दे, इकडे दे.
मस्ती करायची नाही.
डॉक्टर, हा सगळा काय प्रकार आहे?
हे बघा, गोंधळून जाऊ नका. मी सगळं सांगतो. ज्यावेळी या सगळ्यांना माझ्या हॉस्पिटलमध्ये दाखल करण्यात आलं,
दोघं ठीक आहेत ना?
साक्षी रिकवर होते, पण अक्षय.
काय झालं अक्षयला?
त्याचा मेंदू डेड झाला. प्लीज शांत हो.
अरे कसा शांत हो? अक्षय शिवाय आम्ही दोघे नाही जगू शकत रे. नाही जगू शकत.
अरे अक्षय आपल्यात पुन्हा वावरू शकतो. होय, फक्त तुझी इच्छाशक्ती हवी. त्याही पेक्षा तुझी परवानगी हवी. हे बघ, ऑर्गन डोनेशन बद्दल ऐकलंस?
अरे पण
ऑर्गन डोनेशन 2 प्रकारे केले जातात. एक लाईव्ह डोनेशन, दुसरं कॅडेवर, जे मृत पावल्यानंतर केले जातं. लाईव्ह डोनेशन मध्ये किडनी, लिव्हरचा काही भाग डोनेट केला जातो. हार्ट, किडनी, लिव्हर हे मृत पावल्यानंतर काही तासातच ट्रान्सफर करू शकतो. कॉर्नियाज आणि टिश्यू हे 24 तासात ट्रान्सफर करू शकतो. येत आहे ना लक्षात?
अरे पण प्रयत्न केले तर तो वाचू शकणार नाही का? त्याचा श्वास चालू आहे रे.
अरे तो रेस्पिरेटरवर आहे. त्याचा मेंदू डेड झालाय. हे बघ, जर तुझी संमती असेल ना, तर तू किमान 4 लोकांचे जीव वाचू शकशील, किंवा त्यापेक्षाही जास्त. तुला फक्त फॉर्मवर सही करायची. अरे तुझ्या एका कृतीमुळे आपला अक्षय आपल्यात वावरू शकेल, बोलू शकेल, सोबत राहू शकेल. खरं तर आज अक्षय गेल्याचं दुःख आहेच, पण करण आणि साक्षी खूप आनंदात आहेत. खरं बघायला गेलं तर ऑर्गन डोनेशनमुळे आज साक्षी आणि करणला त्यांचा अक्षय नव्या रूपाने भेटला, वेगवेगळ्या रूपात.
साक्षी, एक फोटो तो बनता है यार.
ऑर्गन डोनेशन, अवयवदान. माणसाच्या मृत्यू पश्चातही कुठल्या ना कुठल्या स्वरूपात चिरंतन राहण्याचं दान. खरं तर कायद्याप्रमाणे कुणी अवयव दान केले आणि कुणाला ते अवयव दान केले गेले हे गुप्त ठेवलं जातं. पण सरकारी यंत्रणेनं अवयवदानाच्या प्रसारासाठी आणि प्रचारासाठी एक स्पेशल केस कन्सिडर केली. त्याच आधारावर ही कलाकृती तुमच्यापर्यंत पोहोचू शकली.
Ashwini, I think you can start with the questions that have come in.
Yeah, so Dr. Shruti would like to recite a poem written by her patient. And then Dr. Ganesh is going to ask few questions and then I will join. Dr. Shruti?
Yeah, so I'll just share the screen. So I'm sure you all were emotionally touched by this movie. And every year we have a Kidney Chronicles by Narmada Kidney Foundation. We have at least 10 films which are screened after elimination. Now this year we have a competition for, one second, I think the wrong share. We have a competition for poems this year, and we have received a beautiful entry from one of my patients who has undergone a transplant. Would like to share this. So if not for you, a tribute to a donor. If not for you, there would not be me. That gift of life you gave me. There were tears of joy, there were tears of sorrow. You gave me hope for brighter tomorrow. I wiped away the tears, tried not to cry, knew someone would live and others die. The only way I could understand was to realize this was a part of God's plan. Not for you, what would I do? God chose someone special, He sent you. Now a part of you in me has thrived. Thanks to you, donor, I have survived. And with each new day, this thought comes through. I would not be alive if not for you. So this is a touching poem which one of my patients have written, but this is from a living donor. But you know, just imagine the pride of people who have been waiting and waiting for organs, and one fine day they receive the gift. So I think now we can start the questions.
Very much, Dr. Shruti. It was really a very touching and inspirational video, as well as this poem. What we all lack, even in our medical fraternity, is the awareness about organ donation. I'm sure AMC is a huge organization of 13,000 plus members. Even if they all today pledge and make a registration for organ donation, it will make a huge difference to the society in turn, and they themselves then indirectly or directly promote and further promote this organ donation in the society. That will be creating a huge impact for entire society, and it will help and save so many lives which are in need and in waiting. So thank you again to all the esteemed panelists for wonderful and quite informative sessions on various topics on organ donation. We have few questions by the participants. So we'll start by one. So the first question I will take just. Dr. Ashok Shah has given one question. I will just read out. Most of us believe in rebirth post-death. Can there be possibility that on rebirth, maybe newborn, be born with congenital defect, like born with only one kidney, autism, mental illness, vision defect, etc. Can this congenital defect be because of organ donation in previous life? Just a hypothetical or philosophical question. Any one of the panelists is welcome to answer this question.
Audible. Sir, your voice.
There is a small request to all the panelists to switch off. all panelists, please keep yourself muted if you're not answering, because there is a lot of disturbance which is coming from somebody. Thank you.
Okay, I will read the question again. Am I audible now?
Yes.
Okay. So Dr. Ashok Shah has asked this question based on a rebirth, that what he is saying, that in rebirth, we observe so many newborns are born with congenital defects, like one kidney, autism, mental illness, visual defects, etc. Can these congenital defects be because of organ donation in previous life? Just a hypothetical question he has asked, but is there anyone who can actually guide that, guide Dr. Ashok Shah about it, please?
Ashok Shah, Dr. Ashok Shah, I would like to take the question. If we think of rebirth and we just think of future, we will not be doing noble deeds in this life. We have been given this life. It is a gift which has been given to us. And when we pass on, we have to pass the gift and go. That is all science can understand today, because even in our mythology, if you see, if you have a lot of anecdotes from our mythology. If you know the sage Rishi Dadichi had donated all his organs. This is a myth. This is a mythological story that he had donated all his bones so that a weapon can be made out of the bones and a evil person can be killed. So even our mythology, be it Bible, be it Quran, be it Gita, be it any literature, every literature says that donating yourself selflessly is the most noble deed anyone can do in their own justice. Now, being alive and giving an organ is even more brave. Now, once you have passed away and your body is just going to be cremated, a soul can never be dead. So how can a soul be congenital defective? It cannot be defective. We have to think, open our minds and think like that. I'm being a little brutal, but that is the truth, that if you read everything, even the Quran verse says, donate yourself for the good of people. That is how things will be. Like we always say, Kalyug hai, Kalyug hai. Satyug will never come till people become good. That is all I can think of.
Thank you so much, Dr. Shruti, for the wonderful answer. We all agree with you that we all have to create more awareness and save lives through this noble path of organ donation. And I'm sure very much that this question is answered well. We'll move on to the next question. There's one anonymous attendee who has put up the next question. Once the transplant is done in ABO incompatible post-transplant, how long there is fear of rejection?
I will take that question. So we do the titers pre-transplant. So if we start at whatever titer, at 1/16, we go ahead for the transplant. Post-transplant, for a whole week, we keep monitoring the titers. We do not do anything for the ABO antibodies till the graft shows any problem. And out of say 100 patients, 1 or 2 might require one more plasma exchange after the transplant. Otherwise, after the patient is discharged, we just do not follow the titers. To add to it, many patients ask me this question कि doctor हमारा blood group change हो जाएगा क्या? I said no, your blood group has not changed. You can never receive an incompatible transfusion for any reason. It is only for the sake of organ transplants have we done the desensitization process. And once you are discharged, 7 to 10 days, you do not even remember that this patient has got an incompatible transplantation.
Okay. Thank you very much for that answer. We'll go to the next question. JC Venel has asked age limits for blood donation and exact gap between subsequent blood donations. Anyone can answer actually this.
Can you repeat the question? Sorry.
Age limits for blood donation and exact gap between subsequent blood donations.
Any blood bank person in the group, because we don't want to just say something.
Correct.
Dr. Amit wants to say something.
No, I think the answer to the second question, the subsequent transfusion, I think it's around 3 months. But I don't think there's any age limit. it's just a healthy donor without any obvious comorbid condition which could threaten the safety of the donor. But any adult, I think, but again, as Dr. Shruti said, maybe a blood bank. But I think the second answer to the second question is, I think, 3 months.
Thank you so
I
much.
think 60, above 60 years, they don't accept the blood donation. The lower limit, I don't know, must be 18, but the upper limit is 60.
Okay, thank you, Manoj sir.
It is 18 to 60, like Manoj rightly said, because below 18, they do not have the right to give consent directly. So they don't take, but weight criteria is 45 kilos and above, and hemoglobin 12.5 is the general cutoff point that they are nowadays taking for the blood donation. And 3 months, like Dr. Amit said, yes, 3 months is the gap between two blood donations.
Thank you. We'll move on to the next question. Dr. Aditya Shah has asked, what is the process for registering for organ donation?
I can take the question.
Okay.
So, there is nothing needed to be registered. You have organ donation cards available in any hospital in the city. It is available with every NGO. Yes, Noto has their cards. Even ZTCC has their cards. Any hospital you walk into will have a organ donor card ready for you. You have to simply fill the organ donor card, your name, your details. At the back of the card, you will have blood group, you will have your age at registration, you will have the name of next of the kin whom you have discussed the organ donation wish. This is very important, because if you do not discuss this with the next of your kin at the time when organ donation permission is required, that next of the kin may not know that it was your wish to donate. So the card simply is a living will which remains with you wherever you go. So this card can be laminated and kept in your pocket like your driving license. Whether you are in America, whether you are in Australia, whether in India, once that card is seen by the treating doctors and they believe that you are brain dead, they will ask the next of the kin that this was the wish of your near and dear one. Do you wish to go ahead? Simple. You don't have to register anywhere. You just have to carry that living will with you wherever you go. And this is just a wish. It is not a legal document. It does not mean that treatment will not be given. It just means that in event of a brain death or in event of a cardiac death, if possible, organ donation will be taken care of as per your wish. So do not get into that tension of registering somewhere. Just pick up an organ donor card, and in fact, any hospital, any NGO can give you the organ donor card. It's a wish.
Can I just butt in here a little bit?
Yes.
See, registering yourself in a particular organization like Noto or ZTCC or all, that gives you a card which you can carry with you wherever you travel. So in case you are not with your near and dear ones and you are somewhere away and that card is available, at least your wish is known to the other people, which otherwise may not be known. So that it definitely helps you. And that is why registration should be done. It is not mandatory, like Dr. Shruti said. It is definitely not mandatory. It is your wish. But how will the other people come to know your wish? Once you are dead, you can't come and tell. So if the card is there in your wallet or on your person and people see that you have registered yourself as an organ donor, it means that you wished to donate. And then your relatives will carry forward that wish for you. All right, so that is the advantage.
I will throw some light on this. I will give you a small example which happened day before yesterday only. There was one person who came to Mumbai from Indore, and the family member knew about his wishes. In Mumbai, he had a severe, massive cardiac arrest, and the family did all their best. They donated skin, they donated eyes, and lastly, they did body donation also. So the family members have a very important role to play, because they are the one who will coordinate between the eye banks, skin banks, the hospital authorities and all. So I think the person should explain everything to the family members. All the members of the family should be aware about organ donation, eye donation and skin donation.
Sir, I have a question. Sometimes there is a conflict between the family members about donation, even if the card has been filled. I have seen this happening in many families, that there is a conflict. The person has filled the donor card, but after the death, the donation does not happen because everybody is not in the same page. What is the status of this donor card? And is there any guideline as to what can be done?
At that point of time, we just have to, we cannot do the donation, because every member has to be, they have to give the permission, the consent of, if somebody is having any objection or somebody is not willing, we many a times go to the patient's residence, and if the brother or one of the sister, or if any of the near family member is not willing, then we just tell them that this donation will not be possible, because the consent is very important.
Yeah, again, here I would like to put in a point, like AMC, I said we are working on something called like a living will. So where the patient, before he dies, signs a legal paper saying that he does not want the resuscitative measures to be taken. So in the similar fashion, if he can sign at that particular time and say that, yes, I am willing, I'm wanting this to happen, maybe a legal procedure can be set up. So let's work on it. You know, always we should do our best. We should try our best. So we'll try to work out a legal way of doing it so that the relatives later will not be able to say no if we have a legal paper. So there was one small input over here that I wanted to put in, is about eyes and skin. All right. I understand that eyes and skin, like the time is the essence, you know, about over here. You have to take out the eyes and you have to take out the skin and it transport it. Like we are training technicians, couldn't we train our own doctors, you know, in whose hospitals these patients died? We have one fabulous doctor with us, Dr. Rajendra Chauhan from Palghar. He's a gynecologist, but I know that he gets calls from all over the periphery of Mumbai. If any patient wants to die and donate the eyes, Dr. Rajendra Chauhan is always present over there to take out the eyes and put it in that box and transport it to the center. So if doctors only can get a training center like this to take the skin and to take the eyes, then maybe we will not have to wait for that time in between, you know, which we lose, precious time that we lose. So let's look into the training factor of doctors as well, if we could possibly do something like that.
Dr. Nilima, since you are also a lawyer, I just want to add one more question came just now in the chat box. That is there a role of legal euthanasia in patients who are terminally ill or brain dead to facilitate transplants? What is the view of you or any of the panelists on this? Can you throw some light?
I think I just answered that question, because euthanasia as well is as yet not legalized in our country. So we are working on something called as living will. And we are trying to go to the Supreme Court saying that it is our fundamental right to decide what happens to our body and nobody else can take a decision on our behalf. So we are working towards a very, very finer points of what a living will could entail. And yes, organ donation, we will try to see to that this also becomes part of that living will. So yes, we'll be working on that.
Yes, thank you so much.
Okay, thank you. We'll move on to the next question. Okay, there is Dr. Dipesh Trivedi has asked, can you please comment on non-heart beating donor in or out of hospital?
I can take that if
okay.
anyone wants to, and people please add in. So non-heart beating donors are known as donation after cardiac death. It is known as DCD. So this is done very, very frequently in Western countries because they have everything. I would say they have more awareness and they have more protocolized approach to a cardiac death.
There's a request to all to keep their microphones silent. Thank you.
So what happens in a donation after cardiac death is there are two types of DCDs. One is a controlled DCD and one is an uncontrolled DCD. So controlled DCD is that a death happens in a hospital, in an emergency department, or in an intensive care unit in front of you. There is a CPR cycle given. There are at least 6 CPR cycles given. And then if you know that this is a futile exercise, you talk to the relatives and they say, okay, we give up. We are not going to be able to revive. That is the time. This is a controlled DCD that the doctors and the medical staff have the entire situation in their hand, because remember, when the heart stops, the perfusion to every organ stops. So when the 6 cycles of CPR, that means you have continuously perfused the organs with the CPR ongoing, and then the family says that we wish to donate, we immediately start perfusing the organs with a perfusionist there with cannulas and cold perfusion to all the organs. And this can be taken ahead as a controlled DCD. What is an uncontrolled DCD? A person arrives dead in the emergency department. के patient को ला रहे थे, रास्ते में अभी कुछ हुआ है. So it is like the patient is just dead. You start doing the CPR. You're not prepared that such a patient was coming. And you take the patient to the OT after 6 cycles of CPR are done. That is the Maastricht protocol. And if there is no revival, the family says, please go ahead with the organ donation, and the organs are retrieved. Obviously, in the uncontrolled DCD, the organs like kidneys, lungs, heart might receive an ischemic insult. Now, on the other end, if someone dies at home, eyes, skin can be easily donated, like Dr. Girish has said, Dr. Keswani has said. So these are the organs which within 4 to 6 hours, if you retrieve the cartilage, bones, skin, eyes, these can still be valid because of the blood supply, which is very minimal required in these centers. But when you have vital organs, you require a controlled or an uncontrolled DCD in the hospital setting to get this going.
Yeah, so I think just to add, Shruti, basically, yes, it has really the next big thing in cadaveric organ donation. So it especially was predominant in Spain. It started with Spain, and now it's like becoming more and more common all over the European countries. So I think liver is one of the organs which can be transplanted after DCD, and almost like in Spain, because of DCD, the organ donation rate has gone to 30 per million population, which is like huge. So in those countries, most of these European countries, if a patient, say with an acute liver failure is listed, there is a 80% probability of getting a donor within 48 hours. And one of the reasons, especially in Spain and all, is the DCD, which is picking up, and the other European countries also following suit.
Since Dr. Shruti mentioned about the CPR, let me just make a small awareness kind of a comment just for a minute. CPR essentially, this has got nothing to do with organ donation, okay? But the CPR is something, again, very close to my heart. And each and every doctor should know CPR, and each and every doctor should try and motivate his staff and his members and his patients, and go to colonies and go to residential areas and try and teach CPR. What CPR does is only tries to keep the heart muscle having its blood supply going on. For about 18 to 20% of patients only, I think if it's done immediately, it works. Otherwise, it doesn't work, but it keeps the heart muscle, the blood supply of the heart muscle ready, so that when your AED comes in, the heart muscle can respond. That is the importance of absolute of giving CPR immediately whenever you see a patient in cardiac failure. Thank you.
Thank you, madam. We'll move on to the next question. Dr. Anil Parikh has asked, specifically to Dr. Shruti, can a donor give kidney and liver simultaneously?
A cadaver donor or a deceased organ donor can give both these organs simultaneously, but a living donor, ideally it is very difficult because the liver donation, hepatectomy, is a big surgery. In exceptional circumstances, yes, we can do that if the donor is fit, but ideally we do not encourage people to donate both the organs at the same time, although I have seen patients where a donor has donated a liver first. The liver has been stabilized, patient remained on dialysis, and then the same donor has given a kidney to that same living recipient. So this can happen, but simultaneously is difficult.
Okay, thank you so much. Dr. Ashwini will take on the next set of questions. Thank you.
Thank you, Dr. Ganesh. So the same question would Dr. Amit also would like to address?
Yeah, so living donor, simultaneous liver kidney, no. But sequential, maybe yes. But simultaneous, I think whenever we have a patient who needs both liver and kidney, it will have to be two donors, living relatives. Cadaveric, yes, definitely.
Okay, thank you. So next question to Keswani sir, does keratoplasty require immunosuppressive drugs as in other organs? Dr. Anil Parakh has asked this. Dr. Keswani?
No, we don't have ophthalmologists doing it, but this does not require immunosuppressants. Only it's a corneal implant.
So there's one more big question which we need to ask to Dr. Keswani. Sir, are you there, sir? Okay, I'll call till the time we will take the next question, because there's one question which has been asked for the entire setup. And I'll call him. Till then, we can take the next question to both Dr. Shruti and Dr. Amit. I think you have already addressed this. So but is there any SOP which has been asked? Okay, so if patient has received ABO incompatible organ, if need blood transfusion in future, what are the chances of organ rejection? I think both Dr. Shruti and Dr. Amit can take it.
No chances of rejection due to blood transfusion, because the blood group antibodies have taken care of the organ at that point of time. Like I said previously, post discharge and post the organ settling down, we don't worry about blood transfusions in the future. Yes, but blood transfusions give HLA antibodies. So every time a blood transfusion is contemplated for a transplant patient, even if it is ABO compatible, you use RC1 filter because it filters out the WBCs which have HLA antigens on it, or you give leukodepleted blood.
Yeah, completely agree. Completely agree.
Dr. Amit, you want to add? Because even in the clinicians, there's little hesitance for this.
No, I think what Shruti has made a very, very relevant point. She's an expert in immunology, so I completely endorse what she says. So once the patient is discharged, so as she said, like we have done a couple of ABOI transplants in the last month, and the same thing, we just follow the titers daily till day 7. If they go above 1:64, we may do a session of plasma exchange. But once the patient is discharged and the patient has been desensitized, protocol has been followed well, I think then we just treat it like any other compatible transplant recipient, sorry.
Okay.
Basically, no difference between compatible and incompatible after discharge. Simple.
Absolutely.
Okay. So we need not worry. Maybe we can have a detailed session only for that. Till Dr. Keswani, we get Dr. Keswani, sir, I would like to again address both the doctors. It's a simple question which they have asked. Whom should relatives contact for organ donation if there's death at home? I think even Dr. Nilima or Dr. Hemant can address this. Whom should relatives contact for organ donation if there's death at home?
At home, only organ donation team and eyes. All other living organ donations cannot be done because the circulation is not maintained. So there are numbers. I'll put the number of a rotary blood bank, the eye bank, where the technician comes at home and collects the eyeball. Plus, our technician also will be trained for skin. And skin also, the online numbers are there by Dr. Keswani's Skin Bank, and they also come home and collect the skin. So these are the two things. All other things are complicated, and like cartilage donation, bone donation and all are a bit complicated, and to do at home may not be feasible.
You have to take the body to Tata Hospital for the cartilage and bone donation.
Yeah.
Okay, so that is a added point. Okay.
Please share the numbers on the chat box, please, Dr. Manoj and Dr. Girish.
Yes, yes.
Sure. So, Dr. Shruti, Dr. Amit, what are the prerequisites for perfusionist for DCD? Any protocol to be followed?
So a lung or a heart perfusionist is what is required. Every hospital has that, and we have cannulas which are ready. So usually what is the protocol is that we have our solutions like the UW solutions, or we have a cold Ringer's lactate solution which is ready. And as soon as the DCD protocol starts being followed, the cannulas are inserted in the inferior vena cava via the femoral vein, and it is inflated till the level of the diaphragm, and every organ is perfused with cold saline, so that till the organs are retrieved, the organs remain perfused and cold. And this all procedure happens within 15 to 20 minutes. So the perfusionists have to be standby to see that everything. And we also have ECMO machines available in the hospitals nowadays. Many specialists are there. Dr. Anil Parak is our anesthetist from Global Hospital. He is very well aware that we have ECMO machines, which are sophisticated machines where the blood goes through the oxygenator and goes back into the blood, into the system. So all the organs, even if the heart is not functioning, the heart is standstill. Heart is only a pump which sends blood to all the organs. So we need the ECMO to give blood, oxygenated blood, circulating through the system, and that can be done very well with an ECMO. And the perfusionists are very expert in just connecting the circuits. Within 5 minutes, we have done this protocol in Global Hospital a few months ago, and it could be set up very fast because now the team is very tuned to get into action immediately.
Yeah, completely agree. Only the thing is, yes, the DCDs, the harvesting has to happen, or whatever, the transplant, the harvesting procedure has to start within 30 minutes of DCD. In the sense, after that, it's usually a problem.
Okay. So one interesting question from Dr. Deepesh Trivedi. For pediatrics, it is more or less similar issues with transplant except donor availability. Also in pediatrics, live-related liver is a good possibility. Any insights for pediatric patients?
In fact, pediatric transplantation is it's a whole big challenge, and in fact, now the ZTCC and we have, as part of ZTCC, we have all agreed that we can actually be using the same cadaver for 2 patients. So a pediatric usually needs a smaller volume, so just the left lobe of the liver is good enough. So living related is actually not a big problem in pediatric because the donor safety is not an issue. Left lobe hepatectomy, we are never worried about the volume in the donor. But if there is no donor available or if there is no blood group matched donor, then a same cadaver, we can do what we call as a split. We can split the liver and use the right lobe or the majority liver for the adult and the left lobe only for the pediatric. Though it does not happen routinely, but I think that is somewhere the liver transplant community will have to create some awareness amongst itself. Many a times we want the best for our patient, but maybe at times we do not want to share the left lobe because we feel that may not be enough. But going by the living donor scenario where we have seen that 60 or 70% of the liver is good enough, the same should actually hold good for a cadaver. So if the cadaver liver is very good, if it's a good quality liver, young patient, there is not much of fat, then we should actually be using the same cadaver liver for 2 patients, one an adult and maybe a left lobe can go to a pediatric patient.
Okay. So Dr. Neena P has asked, after liver transplant in a woman, can she become pregnant?
Yes, she can, but after 1 year. And we need to avoid certain immunosuppression medications. It's a recipient, right? It's for the recipient she's asked, right?
We assume so, maybe.
Yeah. So generally we avoid pregnancy in the first year after transplant. After 1 year, she can conceive. and we need to stop mycophenolate or azathioprine if the patient is taking that, because that is teratogenic. So generally, pregnancy is safe. It is very well known, and it is a lot of our patients who have had acute liver failure in the younger population have become pregnant, and absolutely no issues. But after 1 year.
Okay. So, Dr. Keswani sir, are you in, sir? Okay, I think we are not able to get, sir. We have sent a message. Yeah. Till then, there are some questions which have come in chat box, even that we could take, since this could be of really help. So those were not the routine questions in the QA session. So
Ashwini, 1 minute. Dr. Keswani is there. Can we have those questions first? I can see National Burn Center. Yes.
Good afternoon, everybody. So Dr. Keswani had to leave for an emergency procedure. I'm Simran Thakur, a skin bank officer at National Burn Center. So I'll be addressing any questions related to skin banking.
Okay, so the little larger questions, please see if you can. Who bears the cost of processing of skin? Do you charge money from the recipient? If yes, what's the cost? Does it require lifelong immunotherapy, and what are rejection percentage?
So no money is taken from the recipient. A minimal processing fee of the skin processing, which takes 45 days, is collected. Also, this cadaveric allograft is used as a temporary dressing material for the patients. So since it is from another person, there is a chance of rejection, but for a temporary dressing, this allograft is used.
Okay. And I am sure, but still I'll ask, does blood grouping and matching require for skin grafting?
No blood grouping and matching is required.
This is just to honor the question. And one for, what are the obsolete contraindications for eye or skin donation?
So contraindications include sepsis, HIV, which diseases spread like HIV, active jaundice, any type of active cancer. So these are the contraindications for skin donation. Similar for eye donation, I think so.
Yes, yes.
Okay. So any information on cost of setting up skin and eye bank, and please provide information on bone marrow donor registry. I think bone marrow, Dr. Nilima has written, we will have a separate session. For skin and eye bank cost of setting
eye bank is not an eye bank, it's an eye collection center which does not require any investment. You just require one good trained technician available 24 hours and a helpline number which is accessible every time anybody wants to that. So we at Rotary have, so similar things can be done by anybody. Only thing, the expense is the salary and the transport of the technician. That also the eye banks give a small part as a traveling expense, but it may not be good enough. So that is the cost for eye bank, eye donation center or eye collection center. Similarly, same technician can be trained for even skin collection. So they can do both, or some other technicians can come for skin donation and skin. So technicians have to be trained, and those technicians, you don't set up the full bank. Because multiple banks, as Dr. Keswani said, that yes, they require, but in multiple places. So that way.
Okay. So Dr. Amit, can you please throw some light on dual lobe liver transplant?
Dr. Manoj.
Yeah,
when you said that the collecting technicians can be multiple, that is perfect. But then somewhere there will have to be a center where it is transported for preservation. I mean, you cannot.
It is already there. Already these centers are there, and there the list is prepared, and from there also we get calls for collection. Why? Because see, setting up a bank is a major thing. While this is the easiest thing which can be immediately done, our idea is where if there are multiple places you can collect cornea, store wherever at one place or 10 places doesn't really matter. And there are eye banks which are there, and the collection are set.
Not to set up a eye bank, we have to think of setting collection center. That is very important.
Yeah. So that's what I'm saying.
In all the eye banks, the number of corneas they receive is on the lower side. They require a lot of centers from where they can get the corneas. So setting of a eye bank is not the immediate need of the hour. You have to increase the number of eye collection centers.
Agreed, sir. We are just honoring the questions what we have received respecting that. So now 2 back-to-back questions for Dr. Amit. Can you please throw some light on dual lobe liver transplant?
Yeah, sorry. So dual lobe liver transplant is one of the ways to increase the living donor pool, in the sense whenever we find that the volume is not enough. So this is very commonly practiced in Korea, which is doing one of the largest series on living donor liver transplant. So if the volume which is required for the recipient is not enough, then we can actually have 2 donors who give their left lobe, and then they can be surgically joined together. And so 2 donors coming together to save 1 life, because the volume may not be enough either for the donor or for the recipient. So our team also has done a few, but it is very, very prevalent in the Korean population. Yes, needs very significantly increased surgical expertise. So there are some surgical complications which are more, but definitely adds on to the pool of patients wherein the volumes may not be matching. Second question.
Yeah, so there was continuation of the pregnancy in recipient. In pregnancy in recipient, what is the chance of patient's new liver can be predisposed to fatty liver, preeclampsia, etc.? What care during pregnancy to protect this grafted liver and pregnancy safe? From Dr. Karishma Gupta.
So nothing, see, I would say there is no added risk to the liver per se. Yes, the pregnancy outcomes are a little inferior because these patients are on immunosuppression, but by and large, I would say it is like a normal pregnancy, in the sense we just have to avoid certain immunosuppressive molecules which are known to be teratogenic. Otherwise, usually after 1 year, patients are on a minimum dose of immunosuppression. We can actually manage them on a single immunosuppression and keep that tacrolimus and keep that at very low level. And patients usually do not have any problem if there are no other comorbid conditions. So no added risk, which is known, say, of eclampsia or fatty liver of pregnancy, which are complications in because obstetric complications increasing in post-transplant recipient. No.
That's a very well thought question which was asked. Yeah. So this was one question from
one question.
Yeah.
Dr. Amit, this question is for you. NASH or NAFDL, there is no drug which is coming for the treatment of that, and we see that the end-stage liver disease transplant remains to be the only option. A lot of times we come across the fatty liver as one of the sonography findings. At what stage should a doctor, see that grade 1 fatty liver, grade 2 fatty liver? So when is the right time to tell the patient, please be aware that you're starting to get a fatty liver and you may land up with an NAFDL and, you require. So what are the indications that I should be telling my patient, yes, you require treatment, yes, you require to go for a diet plan or for an exercise plan and get your fatty liver in check?
Okay. No, so this answer would take almost an hour to complete, but in the next, to answer it in 2 minutes, fatty liver, if there are comorbid conditions, so if the patient has diabetes, patient has hypertension, as in the patient has a metabolic syndrome, and if the fatty liver is there, then we treat. If the patient does not have comorbid conditions like diabetes, like blood pressure, and if the liver enzymes are normal, just the sonography shows a fatty liver, we advise lifestyle measures. Having said that, we always look at the liver function test. So if the enzymes are more than 2 times and the patient does not have a comorbid conditions, we would do a fibroscan of the liver to see if there is fibrosis of the liver. So the grade of fatty liver does not matter. What matters is a fibrosis of the liver, whether that fat is causing scarring of the liver. So if there is fibrosis, we treat. If there is no fibrosis, we ask for lifestyle measures. But if the patients have comorbid conditions, then they are at a higher risk of developing fatty liver related fibrosis, then we usually treat them. There are molecules which are available, 2-3 molecules which are available and more in the pipeline, which can at least stall the progression of fatty liver. And there are some molecules which can actually reverse the NASH but it's only after those benefits come after many years. Most important is lifestyle intervention. So to answer the question that if I see the fatty liver, first thing I will tell my patient is start exercising, regular exercise, diet control, check yourself for diabetes, check yourself for dyslipidemia, and start with lifestyle interventions. If the other things are not there, patient is otherwise healthy, liver enzymes are normal, nothing to be done apart from lifestyle intervention. If the patient has high enzymes, fibrosis on FibroScan or comorbid condition, we treat.
Sure. So we have almost only one question is remaining in the QA box, but this was good question in the chat box for Dr. Shruti. What is the success rate if a second renal transplant is required, and what immunosuppressants are given in that case?
A very good question actually, because you know, we have all started transplants say 40-50 years back in our country. Now what is happening is that the first transplants, people who have been transplanted earlier in their life, after 10 to 15 years, they are failing their kidneys and they are requiring a new kidney. Especially children, when they get a transplant at 10 to 15 years of age, by the time they are 40, they will require a second one. Now, what are the problems with the second transplant? First, let me list that down. One is that you've already received a transplant in the past and you've received immunosuppression. So two things. One is your body has received a lot of immunosuppression. Two, because of the transplant and because that kidney might have gotten rejected over years because it is a foreign body sitting in your system, you will have HLA antibodies which have developed in your system. And these HLA antibodies make the life of your second kidney short because they go and attack the second organ. So now, technologically advancing, we have technology where we can identify the specificities of the HLA antibodies and try and choose a donor against whom the recipient does not have antibodies. So this solves our problem of using excessive immunosuppression for the second transplant. Sometimes these patients have to wait for a little longer to get such acceptable donors. So the poem which I read out, this was a second kidney transplant recipient. He received a cadaver donor a few years ago and now his mother has given an ABO incompatible. So he did have HLA antibodies against his father. So his father couldn't give, but we chose his mother even though she was ABO incompatible. So sometimes we have to work around science. We have to see what is best suited for this patient and go ahead with the transplant. Barring that, dialysis is never an option. Transplant always gives you a better, a longer and a good quality life whenever it is required.
Correct. So there is one question from in QA session and one in the chat box. Both I think President can address. They are more of an administrative question and maybe we can have a session later. I couldn't avoid as we need to honor the questions. One is as a primary care anonymous attendee. As a primary care physician, if a relatively fit patient wishes to go for whole body donation, and should he be shifted to tertiary hospital just prior to his death to harvest his liver or kidneys, and who will bear the cost of same? And I can continue one more. I think most relatives would honor the wishes of the clear departed ones for organ donation, but wary of procedural delay and unnecessarily running around if they consent. For organ donation, we need to have a standard operating procedure which is easy to navigate in minimum time, especially in diseased tissue retrieval program. So I think Dr. Nilima can take that and maybe if we could avoid the first question, whatever you say.
I think more than me, Shruti would be a more apt person to take it because she handles patients who are referred to her at the tertiary center. The question was answered partly by Manoj saying that if there is organ donation to be done at home and death at home, then only eyes and skin can possibly be done, but not the other organs. So I understand that necessarily if you want to have organs to be donated, it definitely has to go to a tertiary center, which is a certified center for the organ transplant. So I think Shruti, you should take this question.
Yeah.
Dr. Nilima will continue. We as AMC also should now put in efforts to have the certification of the organ retrieval, which we can work as an extended program. So we'll not leave it at this. We will definitely work hard towards that. Yeah. So Dr. Shruti now.
Yeah. So we have two types of centers which are registered. That is an NTORC and that is a transplant retrieval center. NTORC means it is a non-transplant retrieval organ center. Now, non-transplant retrievable organ center includes hospitals, nursing homes, which do not routinely do transplants.
Yes.
But they are equipped with ICUs. They are equipped with all the experts who can certify brain death. Once brain death is certified, if it is an NTORC, then our teams can always support that hospital. So ZTCC and Roto Soto has made a policy that every hospital will adopt nearby NTORCs.
Yes.
So say, for example, Global Hospital. It will adopt a perimeter of hospitals who are NTORCs. And if they can support the organ donation in that NTORC, they will do that by sending their teams. If that is not possible, then the patient or the dead person who is presumably dead, what is done practically is this, that we send our brain dead committee, neurologist, intensivist, to actually ascertain whether there is actually a brain death. Because otherwise, practically what happens that we shift a person who is presumably dead, and we might find that he or she is not brain dead and we cannot take organs. Then it becomes a futile exercise. But if we ascertain that there is actually a death, then we will consider transferring the person or the body to our hospital with all the support systems, and it is all borne by ZTCC. Why? Because every time an organ donation happens, the recipient is supposed to be paying XYZ amount per organ received, because it is towards the maintenance of the organ. It is a nominal amount of 10 to 20,000, which is not much, but because heart, lungs, kidney, liver, everything, because this management requires a lot of money. Because there is a ventilator associated, there is intensive care, antibiotics, IV fluids, CPR, whatever support systems, investigations, because we investigate a donor very thoroughly. We do not want any diseases to go by. So one, an NTORC can approach the nearby transplant center and they can send teams. Otherwise, a person who is brain dead will be financially not be burdened once the organ donation consent is signed. So that is why we like to ascertain before the transfer happens, because once the organ donation consent is signed, the family does not have to bear any expenses. Funeral expenses, the hospital will not give, but yes, they will facilitate everything possible to help the family, which we have seen personally. That whenever there is a family who is opting for organ donation, everyone goes out of the way to try and see that, you know, their timelines are maintained, that, you know, bahar se family members aane wale hain, unko dekhne dijiye, body कब मिलेगा, इतने time में हमारा priest ने बोला है cremation हो जाना चाहिए. You know, all this is followed by even us, because they tell us that, you know, the body has to be given by this. See that your recipient comes in on time, because the retrieval will be done at this time. We will not wait beyond this, because the family has to be honored. So I think this will answer. And NTORC is a big thing, which Dr. Nilima, I will need your help also, because, you know, many centers are not going ahead to register as an NTORC, which has to be done.
Absolutely. Absolutely.
And we are willing to go and train people. We are willing to, like, I am the hospital ZTCC, hospital education committee for ZTCC. So I do regular organ donation awareness training for hospital staff, because many a times small hospital nurses, paramedical staff, they're not aware of this concept. So it's better to have them sensitized to the concept, so that when they are faced with such a situation, they know what to do. Now in all transplant centers, we have an SOP in place. So there's no confusion. So once there's a person who is brain dead, the system is activated. The ICU has a protocol which is given by ZTCC, 1, 2, 3, 4, 5. There is brain dead test done at 0 hours as soon as we think that someone is brain dead. After 6 hours, 4 set of different physicians, neurologists, intensivists, internists, who are on the brain death committee of the hospital will do the test again. If both the committees are in agreement that there is brain death, then organ donation will be taken ahead. In between these 6 hours, we will start counseling the family. So we have coordinators who will start counseling the family that possibility hai ki brain death hai. If that is a situation, will you be willing for organ donation? So, you know, these 6 hours are spent in priming the family that probably there is a brain death. If that is a situation, what would you want to do? Because then, you know, last minute, if you broach the family, it's not easy for a family to accept all this. So this is the procedure. Once the consent is given, we have a document which has to be filled from the COVID point of view, from the donor point of view, and this filled document goes to ZTCC. ZTCC then circulates it to all the hospitals who are the transplant hospitals. They will look at the data of the donor and they will say, yes, we will accept the organ if given to us. Some will say, no, we are not accepting, create itna hai, ye hai, wo hai, but all this starts happening. By the time all the procedures start, the cross-match recipients will be arriving at the hospital. Cross-match takes 6 hours. So the retrieval time is then timed accordingly. So that, you know, the liver, the pancreas, because these are all sensitive organs. You cannot have a lot of ischemia time. So we all start planning the transplants based on the retrieval time and the cross-matching time. So there are SOPs in place. There is no problem for that.
Yeah, very well. So quickly, before I hand over the mic to the program committee chairperson, one takeaway message from all of us. So we start with the president today. Dr. Nilima, one takeaway message today.
Awareness, 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 and do not just preach. Do what you want to preach, and that is the way the example has to be set in. So do it first and then leave it rest to the God. And yes, AMC will collaborate. Shruti, we have a lot of work to be done, and we will definitely start these kind of centers. And also, like I said, training of doctors for the skin and eye donation, and also for the registration and the sensitization. We can have one more session about counseling of patients, you know. So I talk too much. I don't just have a single point take-home message, because this seminar has been fabulous. There are so many take-home messages. My portfolio is full, you know. Thank you so much for being there. Thank you.
So Secretary, sir, one takeaway message.
Can I request everyone to keep their videos on, all the faculty? We would like to also take one screenshot, since now we don't, today's is not a physical program, but we really appreciate everybody's time. I think Dr. Dugard is not connected. Let's go to the speakers. Let's have one line message. I think Shruti has given a lot of messages, so we'll put you last. Let us start first with Dr. Trivedi. Dr. Trivedi.
My simple take-home message is that whenever you come in contact with some death in your family member, in your society, please try to motivate the family members, because many times you lose a young person, they are in a state of shock. So you can be the link between the eye bank and the skin bank and making the things happen. So this is what I would always tell. We Rotarians always do this thing. We try to make it a point that we will make the donations happen. Because we all know eye donation hota hai, skin donation hota hai, but when it comes to real donation, we miss out a lot of donations.
So sir's message, thank you, sir. Your message is motivation.
Motivating the family, yes.
Let's have from Dr. Keswani's team, what is the one line message can you give us? You're muted.
Sorry, we just have to create more awareness about skin and eye donation, because people aren't aware about it and we need it. So creating awareness is must.
Thank you so much. From Dr. Amit Mandor.
Yeah, a wonderful session. I think, as everyone has said, motivation, increase the awareness. I showed you the data, how dismally we are doing when it comes to the mismatch between the cadaver and live-related liver transplantation. Must tell you, hepatectomy is a major surgery. It always carries a risk. So if we can increase the cadaveric pool, it would be a huge boon to our liver patients. And our patients are sick because we cannot maintain them on any dialysis. So increase cadaver so that we can transplant them early and increase their overall life, of course. Thank you.
Yes, thank you so much, Amit. A brief message, Shruti, from you.
Don't take your organs to heaven, for God knows they are needed here. Organ donation is a bridge to heaven.
Thank you. And last but not the least, Dr. Manoj Patel, who has been our...
As Shruti said, recycling of anything, rather than wasting or throwing away or dumping or burning, recycle the organs and go to give life to others. Other thing was the eye donation center. I have already put the number of Uttam Ramdan, who is the technician, in the chat box. So anybody who is interested can contact him at the number, and he'll come and collect. He can go up to Bhayandar, Virar also he goes. So that is not a problem. And our Nova cell, I think all the nursing homes have to be, because there's so many patients who have their last times in the hospitals or nursing homes. So if they are motivated, they can do a lot of work. Thank you.
Wonderful. Is Dr. Dugard there with us? Dr. Hemant Dugard? I think his connection is not there. So Ashwini, yeah, we can wind up now. Yeah.
Yes, ma'am, you can start with the vote of thanks.
So thank you very much. And it's my pleasure and privilege to give the vote of thanks. But before I end, I would like to first of all say all those participants who have been here till the end and those who want to share the knowledge, we are going to keep a recording of the webinar, and the link will be shared in the chat box also, and you can approach us for the link. So if you have missed any part of the webinar or you want to go through it again, we have recorded the entire thing and it can be viewed. You can see the message in the chat box. It's my pleasure and privilege to propose the vote of thanks, because it's very important that, as they say, teamwork. Together, everyone achieves more. And that's the whole message, which I think is coming through in this today's wonderful program on organ transplant. It started, of course, with our president's idea of having this theme, supported by our secretary, Dr. Dugard, and our convener, Dr. Manoj Patel. But very important, our speakers, who are such doyens in their own field and have actually done work at ground level, have come and shared their knowledge and have been there till the end to answer our questions. Dr. Shruti Tapiawala, Dr. Amit Mandot, Dr. Sunil Keswani, and Dr. Girish from the Rotary Club, who has been doing a lot of work. And of course, Dr. Manoj Patel has given his practical points also. But we cannot forget to thank our partners, Finovate particularly, and Pranab for the technological support in a webinar, which is very important, and our office staff, particularly Pramila, for helping us with the flyers and preparation of everything. But last not the least, dear participants, for all of you for spending your valuable time on Sunday morning. Being on time is a good thing, and all of you were there from the beginning and have been there till the end. So I hope you have a lovely, happy, rainy Sunday and enjoy your lunch. Thank you for being here with us. And it's been my pleasure and privilege as PCC to be here in the program with you all. Thank you very much for your time and have a great day.
A reminder again to all of you about the Doctor's Day celebration. A last line from me regarding the organ donation is that live your life even after death through the breath of others. Your soul is your own, it never goes. All right, your organs get changed by the next body. So do not worry about your organs right now, do a good deed. I'm hoping to see all of you during the Doctor's Day program, 3rd of July. A link has already been sent. A chart has also been shown as to which seats are still available. The seats are truly filling fast. So I would want you all to book your seats as early as possible. A lot of interesting announcements to be done on that day, and I do not want you all to miss it. I want you to be physically present to see what we are wanting to announce. So
yes,
bye from me.
Thank you, Nilima. And last but not the least, our good MOCs, Ashwini and Dhyanesh, thank you very much for seamlessly handling the program and also coordinating with all the speakers. Thank you, both of you, for your valuable time and inputs today. Thank you very much.
It's a pleasure.
Reena, a special thank you to you, because it always happens, you know, the PCC doesn't get thanked because the last person who does the thank you doesn't get thanked. So thank you, the MOCs, fabulous job, Ashwini and Dhyanesh, you are such sweethearts. And Reena, as always, fabulous.
Thank you so much.
We need to get back and we are going to work on this. All right. And it was a pleasure to have all of you. The speakers were fabulous, best choice possible. And we are going back with a lot of knowledge. Thank you so much.
Thank you. Bye-bye.
Thank you. Bye. Bye.
Bye.